1, 2, 3.
That's perfect. Thank you very much.
Just so you're aware.
I think it's going to be Zoom. It's that reverb thing. It's not going to be directly that, but it's picking up something. But we can, David, for the live broadcast, we can keep his microphone here and do that. Yeah, I'm picking up. Sorry, have you started a Zoom chat between you? So I'm hearing the audio from here. I'm hearing myself.
and take off video.
Good morning. Welcome to Menarini first masterclass of 2020 in these peculiar COVID times. My name is Francis Lynch. For those of you who don't know me, I'm the General Manager of Menarini Pharmaceuticals. Over the last 20 years, a lot of you will be aware that we have been very much involved in postgraduate education, and it's something that we like to pride ourselves in providing. Today is, I suppose, the most peculiar. We have had webinars in the past, but this is the first total virtual meeting we've had of this sort, and so we look forward to a productive day. Our chairman today is Dr. Ray Wally, who needs no introduction to those of you in general practice, past president of the IMO, and very much to the fore in the fight in regard to COVID. We're also joined by Professor Stephen Lane, respiratory physician at Tala Hospital, Professor Ivan Casserly, consultant cardiologist at the Mater Hospital, and Professor Luke O'Neill of Trinity College, who again has been very much out there in the media and very much part of the education process with regard to COVID-19. Menarini is involved in over 8 therapeutic areas, and one of our representatives will explain to you some of our products we have over those areas later on. So look, I hope that you will enjoy today's meeting. We're doing this in the peculiar circumstances of COVID-19 and have, as part of our responsibility since the beginning of this outbreak, for the protection of our staff and the protection of healthcare professionals, we have been not knocking on your doors and, generally speaking, trying to meet you in a way that we very much welcome and appreciate that you have allowed us to do over the years, and we look forward to getting back to that one of these days. But in the meantime, I hope today's meeting will be educational and productive. Thank you very much.
Good morning. This is all a bit of a surreal experience where I am. I'm in Croke Park, and I've got 2 gentlemen with me, David and Mark, who were live filming this. Croke Park, the Doyle Hotel beside Croke Park. So excuse me if there are mistakes, because it is live, and the best things happen on live broadcasting. So I'm Dr. Ray Wally. I'm a GP in North Dublin. As we've had a lot of new experiences in COVID in the last 6 months. So as I said, this is a new experience for me. We've got an interesting selection of speakers. I'd like to first thank Francis for his introduction. I'd like to thank Menarini for facilitating this educational process today. I think we've missed many of these educational meetings in the last 6 months, and hopefully this is the first of many. This morning we have an interesting selection of speakers in the fact that we've got Professor Stephen Lane, Ivan Casserly, Luke O'Neill, all well-known names in their own right. I'm going to first start with some slides in regard to the deal in regard to chronic management of certain ailments which you're going to be dealing with. I've got a first slide up there, which is a slide that we used when we were introducing this many moons ago at the start of the year or the end of last year. I'm going to go on to the second slide because that refers to the different parts of the program that were then. It was a chronic disease program. The plan was that we would be dealing with the over 75s in 2020, and this would progress on. This is the slide that we used in presenting this when we were presenting this at the start of this year. That has moved on because of COVID. We're in a different world now, as you well know, and we've modified the program such that the age has dropped to 70 because we obviously weren't going to get people in during the time. And patients will receive a structured scheduled call with GP, or people will be brought to the surgery. IMO members would have received these educational by way of a presentation earlier in the year, and also subsequently when the renegotiation occurred. These are the monies that are going to be paid in regard to chronic care. It's going to be nurse assessment with investigations together with general practitioner assessment too. And these are the listed ailments: asthma, type 2 diabetes, COPD, heart failure, ischemic heart disease, cerebral vascular disease, stroke, minor stroke, TIA, atrial fibrillation. We hope that the second part of the deal should go forward then in the new year as well. This is due to come in January 2021. Further information will go out to IMO members in the future in regard to that. You're delighted to know that's my last slide. I'm going to introduce the first speaker, Professor Stephen Lane. Stephen is a consultant at Tallaght University. He's also a professor of respiratory medicine at Trinity College, and he's part of the clinical advisory group for the National Clinical Programme in Respiratory Medicine, Asthma and COPD. He's got a special interest in asthma and COPD, and we all recognise him as an internationally, sort of involved in international collaborations in regard to these active clinical programs. I'm going to pass you over to the next slide, and I'll be coming back to you in between speakers. Thank you very much.
Good morning, everybody. I'd like to speak to you today about confronting unmet need in COPD in Ireland 2020 and some personal insights from COVID. The narrative of COPD has changed a lot over the last few years, so a lot of what I'll be talking to you about will be new, and I'll be introducing some new concepts. I'd like to thank Eamon Arini for the opportunity to speak with you today, although this is an unusual time, and we'll see how the virtual conference goes. These are my disclosures. The objectives of the talk today are on the following slide. I'd like to review the international and national epidemiology of COPD, a different take on the pathophysiology of COPD, introducing the concepts of preload and afterload, the natural history of COPD with a focus now on early and pre-COPD, which is new. The whole problem of COPD in non-smokers will be reviewed. The role of dual versus mono bronchodilation as initial treatment in COPD as per GOLD 2019 guidelines, and introducing the increasing evidence for the role of inhaled corticosteroids and the evidence for triple therapy in patients with COPD who are not responding to conventional dual or monobronchodilator treatment. There's also now an increasing role and greater understanding of the role of eosinophils in COPD, and I'll give you some personal insights from COVID. Firstly, epidemiology. This is a graph I've taken from the global burden of disease, and you can see here that in the section of non-communicable diseases in 2020, COPD is ranked third in the world. There were 3 million deaths from COPD in 2015, and it is estimated to be 250 million cases of COPD in the world's population of about 6 billion people today. To date, tragically, over the last 6 months, there has been 850,000 deaths from COVID, as you know, and I just put that out there to let you know the comparator of 3 million deaths per year from COPD and what an enormous problem it is going forward. This slide shows the prevalence of chronic obstructive pulmonary disease in different countries in the world, recently published in the New England Journal of Medicine. The prevalence is increasing in most countries in the world, but particularly and worryingly in countries like China and India. In these countries, COPD is not always related to cigarette smoking, and there is increasing incidence now of COPD in patients who have never smoked. And this study here shows the incidence of COPD in different studies and in different countries in patients who have never smoked. And here you see the one that's relevant for Ireland is reference 20. And here you can see that 20% to 25% of people with COPD in Ireland have never smoked. But upwards of 45% of people in countries like South Africa also have never smoked. And this is a really important new finding, that COPD can occur in 20 to 45% of people who have never smoked. So it is not just a cigarette smoking disease. And I'll return to my last slide, previous slide, and here the prevalence of COPD in countries like the United States or Europe related to smoking seems to be leveling off, but the increasing problem now that we're seeing is COPD in the non-smoking population, and we'll come to reasons as to why that might be the case in a while. In Ireland, there's estimated to be 250,000 people with COPD, but the number is probably closer to 500,000. It has the highest hospitalisation rate in the world year on year. And this is a slide from the National Health Quality Reporting System in 2018, showing that Ireland has about 400 admissions per 100,000 population and is the highest in the OECD every year. So we're managing COPD in Ireland very late stage in the disease, at the very end of its natural history. We're managing it primarily in hospitals. We're not picking up pre-COPD or early COPD, preventing this happening. And we have a particular problem in Ireland. This is the breakdown per county, but really the overall average is approximately 400 per 100,000 people. The mortality from other diseases like cancer or here acute myocardial infarction is dropping significantly since 2005, but in Ireland the mortality from COPD is not. We have about 15 to 1,600 deaths from COPD as a primary diagnosis per year in this country, and it's the second commonest cause of respiratory death after lung cancer. Now, I'm going to talk a bit about pathophysiology of COPD. As you know, it emerged around the time of the Second World War, where two predominant clinical phenotypes emerged. On your left, the blue pink puffer, and on your right, the blue bloater. The pink puffer had an emphysematous or hyperinflated X-ray, whereas the blue bloater had an X-ray on your right showing cardiomegaly and interstitial edema. The pathology of the emphysematous patient is on your left there, showing alveolar destruction and a functional narrowing of the bronchial tubes, whereas the blue bloater had anatomical narrowing of the bronchial tubes secondary to chronic bronchitis. They're generally mixed. You rarely get a pure emphysema or pure chronic bronchitic COPD. But the more you veer toward the blue bloater, the worse your prognosis. Blue bloaters have wet COPD. They exacerbate a lot, bring up a lot of sputum, whereas the pink puffer, in its purest form, is a dry COPD and really complains of breathlessness on exertion, which can be very significant. The narrowing of these bronchial tubes because of emphysema or chronic bronchitis occurs across the whole length of the tracheobronchial tree, from the trachea right down to the terminal bronchiole. So you're getting right shift here, and you can see the endoscopic view of narrowing of the final common pathway of narrowing of the airways. The narrowing occurs predominantly during exhalation because the intrathoracic bronchial tubes are much narrower during exhalation than they are during inhalation when they're pulled across. And that's why we have FEV1, peak expiratory flow rate, expiratory wheeze, etc. And we measure that narrowing during exhalation by using the spirometer, and we've had this measurement now since the mid-50s. And the spirometer enables us to measure vital capacity as a function of time. And here we can see normal in the blue that this person is exhaling 3 of their 4 litres vital capacity in the first second of a forced exhale maneuver, giving a ratio, an FEV1 vital capacity ratio of 0.7 to 0.75. Whereas the red line is an obstructed patient. These patients really take a long time. They have a lot of afterload. It takes a long time to get the air out of their lungs. And this particular example here, this patient is exhaling 1 litre of their 4 litres in the first second. So therefore their FEV1 vital capacity ratio is 0.25. Anything less than 0.7 equals a definition of airflow obstruction. When you give a bronchodilator, you can potentially reverse, or at least partially reverse, the airflow obstruction. And here you can see in the light blue line, this is represented here. So bronchodilators work by increasing FEV1 by reducing the afterload. The second pathophysiological abnormality is very important. And I want you to imagine you're asleep in bed at nighttime, and at the end of a quiet exhalation, when you're asleep, the volume of air in your lung at that point is called the functional residual capacity. And I just want to bring your attention to the FRC here on the slide. At that point, at that exact point, the outward forces of the chest wall trying to expand are equal and opposite to the inward elastic forces of the lung maintained by the pleura. If you've got parenchymal destruction in COPD, of course the lung gets destroyed, the compliance of the lung increases, and the chest wall starts winning this tug of war. So you're all aware of the chest wall creeping up, getting bigger, increased AP diameter, creeping up over your trachea until you ultimately get a barrel chest. In these patients, the functional residual capacity is markedly increased. So you can imagine what it's like. These patients are taking a breath on top of a breath. and constant. And this is one of the major mechanisms of breathlessness and COPD: hyperinflation, trapped air, increased FRC. This is the preload problem in COPD. And the second way in which our powerful bronchodilators work is to reduce the preload by deflation. And you can often pick this up by marked reversibility in the vital capacity, not the FEV1, in patients with COPD as that air is increasingly released from the lung with these drugs. So in terms of pathophysiology, the pathology is chronic bronchitis and emphysema, and the physiology is airflow obstruction, which is afterload, and hyperinflation, which is preload. I'd like now to move on to the naming and staging issues we had with COPD over the years. The terminology of pink puffer and blue bloater persisted really up until 1997, and certainly when I was in medical school, in clinical textbooks you would see pink puffers and blue bloaters. When you did your radiology, you'd hear terms of bullous, paraseptal, centrilobular, hyperinflation. Doing your physiology, you'd hear terms like obstructive, restricted, and when you were doing your pathology, you'd hear chronic bronchitis or emphysema. So there was no name for this disease. It was a confusing era of synonyms, different, and it was probably best known by the name of emphysema. But really, nobody really had put this really prevalent or the most prevalent disease together. Until 1997, the great and the good launched the Global Initiative for Chronic Obstructive Lung Disease, or GOLD. And the first thing they did was give this disease a name, and they called it COPD, Chronic Obstructive Pulmonary Disease, in 1997. And the biomarker that they used was the FEV1, the post-bronchodilator FEV1. So COPD is the disease, and then you use spirometry to quantify how severe it was and perhaps have a prognosis and plan treatments and clinical trials, etc. So airflow obstruction was said to occur if the FEV1 vital capacity ratio was less than 0.7, as previously discussed. And then in terms of your absolute predicted FEV1, your COPD was considered to be mild, moderate, severe, or very severe, depending upon your percent predicted FEV1 taken on an annual basis. And with this, the following Fletcher-Peto curves were constructed, where we measured FEV1 over a period of a lifetime. And here you can see a representation of this from 1997, where the blue represents normal. And here you can see that the FEV1 gradually starts to fall off normally in people without COPD from the age of 60 on. In patients with COPD, according to this model, you get accelerated decline in your FEV1, occurring much earlier than that. So your airways are closing over much more rapidly over time, over a lifetime, in patients with COPD. All treatments directed then at COPD are to try and shift this curve back to the right again, i.e. to slow down the deceleration in FEV1. So you could say that somebody who has an FEV1 of 50% predicted, who is 50, falls quite to the left of that orange curve. And this was the thinking behind the Fletcher-Peto curves. But the thought behind it was that you had accelerated closure of your airways over a period of a lifetime, that this was the only biomarker, and that COPD was only a smoking-related disease. In 2011, of course, this was changed, and the combined assessment of COPD was introduced. And this was on the basis that people had very low FEV1s, but seemed to be doing okay, and people with very high FEV1s who were exacerbating a lot and very breathless. So there's a disconnect between that one biomarker of the disease. And in 2011, two further biomarkers were introduced, i.e. how many exacerbations you had in the last year, or how breathless you were. And these Rubik's Cube type ABCD boxes were constructed, where C and D are greater than 2 exacerbations per year, A and B 0 to 1 exacerbation per year, or A and C is not breathless, B and D is breathless. So somebody with very bad COPD would be grade D. They would be exacerbating greater than twice per year or have a hospitalization, and they would be very breathless, as opposed to somebody with A. In 2017, this was changed again, and now we have taken spirometry out of the classification of future risk of COPD. So spirometry and annual spirometry is very important for diagnosing and assessing the degree of airflow obstruction in COPD. But after that, the stratification of risk and prognosis is very much based just on the ABCD criteria, based on how many exacerbations you had in the last year and how breathless you are. So it's now quite simple. It's important to have annual spirometry in somebody with COPD. And when they come to you, that's your assessment. Then you ask them how many exacerbations or whether they had a hospitalization last year, or are they breathless, yes or no. And it's a very simple matter of placing them in the ABCD categories. In general, people in Ireland who have diagnosed COPD are generally very severe B or Ds, because we're treating COPD currently at a very late phase of the disease. We are not addressing early stage or pre-COPD at this moment in time. I'd like now to talk about natural history and how the narrative on this has changed, particularly in light of what we now know about patients who develop COPD who are not smokers. This is your traditional Fletcher-Peto curve, and the arrow tells us that our double-blind placebo-controlled studies that have been carried out to date in about 100,000 people. The average age is 52, average lung function is 50% predicted. So we are investigating and treating at the very end stage of the disease. So we really now need to shift our thinking backwards a little bit, because we only have information on COPD at the very end of its natural history, when there is actually very little that we can do about it. You've seen this slide before. It's telling us that 20 to 45% of people in the world, particularly the developing world, have COPD. That's on the increase. That is not related to cigarette smoking, and it's related to poor socioeconomic factors as children or even in utero, exposure to biomass fuels for cooking and heating, particularly in China and in countries like China and in Africa, or childhood lung infections that are not looked after properly. These type of issues have all been associated with COPD. Cities that are very heavily polluted, in addition, cause increase in COPD in patients who have never smoked. And an interesting example in South Africa, previous tuberculosis in childhood is associated with the development of COPD. So I want to just, this graph is again looking at the Fletcher-Peto curve, but in a different way. It's going back to childhood. And trajectory 1 is the traditional curve where you get normal development and you get normal decline. And the red line is trajectory 3. That is, again, our current thinking of COPD, where you get normal development. You assume normal development, but you get a rapid accelerated decline. And that's what we've been dealing with to date in cigarette smokers in double-blind placebo-controlled trials. But look at trajectories 3 and look at trajectories trajectory 2 and trajectory 4. In trajectory 4 particularly, these lungs are not developed because of the reasons I've mentioned. And so these patients never develop, their lungs never develop normally by the age of, while they're in their early 20s. And if they also have accelerated decline, these patients are also falling into the clinical diagnosis of COPD because they have got failure of gain. We've been concentrating on the very important increased loss, but we now have to really focus on the factors that are occurring in utero, in childhood, that are preventing the lungs actually developing properly. And it's very interesting that when you look at COPD in patients who don't smoke in India or in China, it's often in women. And because it's women who look after the house, who are doing the cooking, who are doing the making sure the house is heated, and they are exposed to biomass fuel combustion particles, and they tend to develop COPD more than the men. So it's a different type of phenotype coming through. This slide is the Fletcher-Peto curve again, but what it's really telling us, what I've done now is I've shifted the arrow back to 20s or 30s. And this is really where we need to be focusing our attention on now, because we know COPD is not just about accelerated loss, it's about reduced gain of lung function. And we really need to be starting our studies back here at this time. And there's a lot of interest now in what we call pre-COPD or early COPD. So pre-COPD is loosely defined as somebody who has got symptoms of cough, repetitive cough, some mucus production, but generally is okay. And when you do lung function, they have normal spirometry and they have normal FEV1 vital capacity ratio. Their FEV1 may actually be at the lower limit of normal, because there is a wide range, it's a predicted value and there is a wide range of normal, but they're not obstructed as yet. Pre-COPD is different from early COPD. Early COPD is somebody in whom who have symptoms consistent with COPD and they have airflow obstruction on spirometry, i.e. an FEV1 vital capacity ratio less than 0.7. We know COPD is a progressive disease. We know if we get in there and treat it early that we can intervene. We know that if we can improve lung function and intervene and diagnose COPD in smoking and non-smoking populations, we can improve quality of life, delay progression, and improve overall survival. So the take-home message from natural history is that we've been looking at late-stage, end-stage COPD in smokers only. We're now starting to look at younger people with pre-COPD or early COPD and looking at the factors that prevent the lung developing or reduced gain of lung function throughout life. And this is going to become increasingly important as cigarettes are phased out in the developed world and as these other factors that are non-COPD factors are going to become more of an issue now as time goes on. So I want to change now to management we've spoken about GOLD and the latest iteration is 2019 and the ICGP and the Irish Thoracic Society have guidelines dated 2019 that you're all familiar with, I'm sure. Our treatment goals in COPD are to reduce day-to-day symptomatology, improve quality of life, but also to reduce risk of death and exacerbations going forward and to reduce mortality. There's non-pharmacologic treatment, which is very important, smoking cessation, physical activity and vaccinations. And the drugs we use in COPD, the pharmacotherapy are anticholinergics like the LAMAs, sympathomimetics like the LABAs, and anti-inflammatory treatments, which are the inhaled corticosteroids. And we give these by the inhaled route in the stable, non-exacerbating situation. This slide is really just to introduce the changes that happened in 2019, that we now step up and step down treatment in COPD as per GOLD guidelines. Whereas before, if you were a GOLD C, you were always a GOLD C and you were treated as a GOLD C. That's not the case anymore. You can be a GOLD C on your initial assessment. You can start your LABA, LAMA or LABA as per this slide. But you then need to review your patient, reassess and adjust treatment either up or down depending on their exacerbation rate and their symptomatology, using just very simply how many chest infections or exacerbations have you had in the last year since I saw you? Has your breathlessness reduced using the MRC score or the CAT score? But the key point from 2019 is that you adjust up and you step up and you step down treatment, just like GINA guidelines for asthma. The studies all address, the landmark study was Uplift in 2008, which really put LAMAs on the maps by Riva or tiotropium, and they showed that you could improve lung function, quality of life, and reduce exacerbations, and even reduce mortality in this quite large initial study. But this was the seminal study in COPD. So I'd just like to delve into a little bit of aspects of management, and as I said, the main things we're focusing on are reducing day-to-day symptoms, reducing exacerbations, and reducing mortality. The evidence today is such that we know that dual bronchodilation, even though the GOLD guidelines tell us that you should start with mono bronchodilators, particularly in ACOPD. But despite that, a lot of people on either a LAMA or a LABA and COPD, most of them still have residual symptoms as per this slide. More than 50% in fact. And indeed, if you do a meta-analysis of control of symptoms in COPD comparing dual LABA-LAMA bronchodilator therapy with LABA alone or with LABA ICS, you find that a dual bronchodilator therapy is much more effective in relieving symptoms of breathlessness and improving quality of life in patients with COPD. So I would strongly recommend you to use dual bronchodilator therapy in all but the very mildest of patients with COPD. The evidence is certainly very strong for that. Dual bronchodilator therapy versus LABA ICS or versus a LABA or LAMA alone. Moving on to exacerbation reduction. Exacerbations are very important in COPD because they predict death. And once you start exacerbating, you really, it's like an accordion. You get your next exacerbation comes very quickly on the next, and you end up dying in very short period of time, in only a matter of 2 to 3 years after you start exacerbating, particularly after a hospitalization for COPD. So exacerbations are very important, and they need to be, any treatment that reduces exacerbation is to be valued. And it's interesting that the majority of patients with COPD die predominantly during or in and around a month or two after an exacerbation of COPD. They also die from other causes, ischemic heart disease, lung cancer, etc., etc. But statistically, they are most likely to die from their exacerbation of COPD. So if you reduce exacerbations, really you're also reducing mortality. So exacerbations are very important. This is the FLAME study in 2016, which compared a dual bronchodilator therapy, a LABA-LAMA, against a LABA ICS. And FLAME, just concentrate on the top panel there, FLAME really showed that dual bronchodilator therapy was much more effective than a LABA ICS in reducing exacerbations. But despite that, and this is another way of looking at FLAME, despite that, even 50% of people, although there was a significant, perhaps a 20% reduction in exacerbations, still 50% of those patients were exacerbating. So there's a huge unmet need. So even though you've reduced exacerbations by using dual bronchodilator as opposed to mono plus an ICS, there is still 50% of these patients are exacerbating. 50% of these patients are at risk of death and recurrent exacerbations and a poor quality of life. So there's a huge unmet need. Just like there's an unmet need in symptoms, there is an unmet need in managing exacerbations. I'd now like to move on to triple therapy, i.e. the addition of an inhaled corticosteroid to LABA-LAMA in the management of certain individuals with COPD, because we're becoming more informed because of the impact and the ethos studies that have been published in the last year on the role of inhaled steroids and who to give them to in COPD. As you know, when you're assessing your patients and upping and downing their treatment as to their gold status, there's a huge unmet need in symptoms and in risk and also mortality in COPD. And therefore, we've been looking much more closely at the role of inhaled steroids in COPD in these studies. The initial study was the IMPACT study, which showed that triple therapy is better, a lot better than dual therapy in improving symptoms and in reducing exacerbations on these slides, and the references are given below. This summer at the American Thoracic Society and just published in the New England Journal of Medicine, the ETHOS study has confirmed the information from IMPACT. And these are very large studies, but again, they are in end-stage COPD, FEV1's 50% predicted, age 62, etc., etc. In lates, we're talking all the time, these studies about late-phase disease. So, as we said, there's a huge unmet need in symptoms and exacerbation reduction in patients with COPD. We've seen that triple therapy is better than dual therapy, is better than monotherapy, is better than LABA ICS. But who do we give the triple therapy to? That's the question. Well, of course, we have to ensure that they haven't got other diseases like asthma or bronchiectasis. We tend to avoid them if their body mass index was less than 18, they were cachectic, they were bringing up purulent sputum on a daily basis, they would be unlikely to benefit from steroids. But also, what about their eosinophil count? This study here shows us that the effect of an inhaled steroid containing inhaler reduces exacerbations at 100 eosinophils per microliter, which is very low. Now that's 0.1 on your full blood count. And as you know, you're often sending full blood counts. You look at your eosinophil in the differential. If it is greater than 0.1 or 100 cells per microliter in a patient with COPD who has got residual symptoms or exacerbation history despite dual therapy, these patients should be given triple therapy as long as you've ruled out other things. So I think we're now quite clear that the eosinophil is very much part of the core consultation in COPD, i.e. clinical assessment, spirometry, what's their gold stage ABCD, does their chest x-ray show anything else that's going on, what's their full blood count. That's the core COPD consultation now in primary care. And the eosinophil is a very important part of that because it tells me that I can give this person, and this person is likely to benefit from triple as opposed to dual therapy or LABA-ICS. I'd like now to move to mortality reduction, which is more or less the same, because mortality and exacerbations are linked. And mortality in patients with COPD, the patients who die are patients who are exacerbating frequently and the patients who are very breathless, i.e. Gold D or Gold B COPD. The effects of lifestyle changes, smoking cessation, physical activity on mortality reduction take 10, 12, 13, 14 years to actually have a benefit. So there's a huge unmet need that that interventions need to address. Just by giving up smoking in somebody with severe COPD is unlikely to improve your mortality until 10 years have gone by. So there's a great unmet need there and potential for therapy. The IMPACT study looked at all-cause mortality and showed that in the triple therapy and in the LABA-ICS arm, there was a significant reduction in mortality, in all-cause mortality over a year. And this in the lower panel was borne out again in the recent ETHOS study. And it would seem to be that it's the inhaled corticosteroid component of the triple therapy or LABA-ICS, if prescribed judiciously, is the main driver of the reduction in all-cause mortality in COPD. And we've known this, and here this slide is showing the main studies that have been carried out in COPD over the last 14 years. TORCH, UPLIFT, FLAME, IMPACT and ETHOS. They are the big headline major studies that have been carried out. All of these studies have shown that they've shown a reduction in exacerbation rate, quality, improvement in symptoms and quality of life, improvement in FEV1, but they've all, in the ones that reported all-cause mortality, showed that they do reduce all-cause mortality in patients with COPD. Now, other than UPLIFT, all of the studies, the major effect were in patients who were prescribed judiciously inhaled corticosteroids in COPD. So I am confident now that patients with COPD, their mortality will be reduced by the addition of inhaled corticosteroids in the patients I've indicated, and if their eosinophils are greater than 100 or 0.1 per microliter. One of the problems with giving inhaled corticosteroids, of course, is that there's a dose and time-dependent increase in the incidence of community-acquired pneumonia. But overall, this is the overall prevalence of community-acquired pneumonia in the community. There's a huge increase in the incidence of community-acquired pneumonia in any event, whether you're on treatment of ICS or not. And within COPD, the inhaled corticosteroids only increases community-acquired pneumonia slightly, as you can see grayed out here. But if you're still smoking, if you're exacerbating a lot, and as your gold stage increases or your BMI drops, your risk of pneumonia increases. So the contribution of inhaled corticosteroids to the prevalence of community-acquired pneumonia is minimal in my view. And this sub-analysis of IMPACT showed that for every inhaled corticosteroids will reduce your exacerbation rate by 20 to 25%, but will increase your incidence of community-acquired pneumonia by 1 to 4%. And there isn't an excess of mortality in the patients who develop pneumonia and COPD. So really, in terms of risk-benefit, you are really, even though there is a risk of community-acquired pneumonia, these patients do not die statistically, and they're getting a much greater benefit and mortality reduction from the use of inhaled corticosteroids in the patients that we've hitherto described. So in 2017, I would have put up this graph saying that LABA/LAMA's dual therapy was the mainstay of treatment with COPD, and inhaled corticosteroids were probably heading off into the sunset. But now this has definitely changed with IMPACT and ETHOS. We now know where and when to prescribe inhaled corticosteroids as part of triple therapy in COPD. It reduces symptoms, it reduces exacerbation, and it reduces all-cause mortality. There are other treatments that it's important that you're aware of in COPD. Again, for very end-stage COPD, pulmonary rehabilitation has been shown in meta-analysis, Cochrane reviews, to be absolutely essential for the management of patients with COPD. It improves their quality of life, decreases reduction, and nowadays nobody would carry out a controlled study on pulmonary rehabilitation in COPD because it has been proven. In addition, in a patient such as this is a man with emphysema, pink puffer COPD, he's 63, he's very breathless, he's very reduced FEV1, 32% predicted, he's got predominant emphysema on his CT scan and on his chest x-ray, and you can see an intact fissure here. So what are the options from here? He's given up smoking, he's doing all the right things, he's on LABA treatment, he's also been started on triple therapy, but still he's extremely breathless. What can we do for him? Endobronchial valve therapy now has been carried out increasingly in the country, and we use silicone and nitinol stents. And what these one-way stents do, we pop them into an airway. It allows air to escape during exhalation, but no air gets in during inhalation. So you would see in this, going back to this scan, you would see that emphysematous airway, and you put a stent, you put a one-way stent in there, do a CT scan again in about 4 weeks' time, you'd find that would have collapsed down. You'd get a line of atelectasis. And what this does is it gets rid of the hyperinflated air, and also it allows the normal lung to be expanding. We're getting fantastic results from this, and this is a study in the New England Journal of Medicine showing exactly that the use of endobronchial valves for emphysema, non-invasive, very well tolerated, shows huge increases in FEV1 and vital capacity, increases in 6-minute walking distance, and particularly major increases in quality of life. So this is a non-invasive treatment that we can that can really positively affect patients with these diseases. Because as I said before, there's a huge unmet need, despite our pharmacotherapy and doing everything in the right way. Going further than that, lung volume reduction surgery, although it's invasive, can work, but it's doing the same thing, and ultimately lung transplantation. But of course, that depends on organ retrieval, etc. And it's not realistic for the vast majority of people with this very common disease. The last issue I just want to address is that of COPD and asthma overlap. This is a child, and these are some of the currently available LABA/LAMA combination dual bronchodilators, and certainly nobody would prescribe a LABA/LAMA to a wheezy child with asthma. But what about this man here? And he's got emphysematous CT, he's of a certain age, and time and time again, I go in ward rounds, this person is on a LABA/LAMA, and they've certainly got emphysema, certainly got severe COPD. But what if this patient had childhood onset of symptoms, coexisting allergy like hay fever? Everybody in his family had asthma. He's got a blocked nose, had 2 polypectomies. His eosinophils are greater than 0.3 or 300 per microliter. Total IgE on a blood test greater than 70. And every time he's given a course of steroids, he has a Lazarus effect within 24 hours. Well, of course he has COPD, but this man also has asthma. And if you've got asthma and COPD, i.e. asthma-COPD overlap, the asthma trumps. You treat asthma, you treat him as per GINA guidelines, not as per GOLD guidelines, i.e. as per increasing the dose of inhaled steroid, etc. So this is not a rare thing. On a weekly basis, I have changed the inhaled treatment of patients with asthma, with COPD, because they weren't doing everything right, but they're still exacerbating. There's nothing new in their x-ray. They've got COPD, but you ask them a few questions, look at their full blood count, send off a total IgE, and of course they have asthma as well as their COPD. You pop them on a high-dose inhaled corticosteroid, and after a short period of time, they start doing an awful lot better. That, in my experience, is the main reason why patients with supposed COPD are not getting better. And it's a very simple clinical thing for you to do, and I've spoken about that before. I'd just like to give you some insights to COVID. It's been quite a stressful time for us all and our patients and society at large, but I think we've done very well as a country in managing it. But one thing I have noticed is that one of my roles, and the consultant's role in there, was determining who was for ICU or not. And this was a really difficult, these were really difficult decisions. And patients who had a diagnosis of COPD were almost immediately declined access to ICU because of the nihilistic approach that is prevalent with this disease. And I'm hoping through my talk today to impress upon you that this is not a nihilistic disease. It's not always associated with self-imposed smoking. 45% of patients with COPD can have the disease because they haven't smoked. And also a lot of these patients have asthma COPD overlap. So if you've got a diagnosis of COPD in a pandemic with limited ICU beds, you are less likely to be intubated. And that's quite a scary thing. It's quite a scary thing. Of course, we were doing CTPAs because of the thromboembolic disease comorbidity in a large number of patients and young patients. And it was evident to me anecdotally that a lot of these patients had early emphysema, and they had otherwise been well with no history and on nobody's radar whatsoever, but it hasn't been looked at in any great detail. Of course, over the pandemic, we were unable to get lung function studies, where we were unable to get our spirometry. It's coming back to normal now, and certainly it was very difficult to get any endoscopy unless patients had a very aggressive cancer. It did bring up some positive things though, and one was the remote consultation, and I thought I was doing consultations over the phone, and I said, well, what is a core consultation? And a core consultation is, demographics, but asking patients how breathless they were, doing their CAT score, MRC score, or trying to quantify how many exacerbations they had over the telephone, which was actually, quite easy. You really do need your chest x-ray. You really do need your full blood count as part of the core consultation. And you really do need to ascertain whether or not this patient actually has asthma or not. And a lot of that can be done over the phone, but of course it's one of the few specialties left that you do actually need to use a stethoscope and place it on the person's chest to see if there's any crackles or wheezes. Remote pulmonary rehabilitation has also become quite popular, and the National Clinical Programme for Respiratory Medicine has an interim guideline on this, and this is really gym classes. So a lot of you might be doing your gym classes remotely, but same for pulmonary rehabilitation. There is no evidence as yet that there is actually a post-COVID syndrome. We hope there isn't, there might be, but we have experience from SARS, we have experience from MERS, and of course we have the annual experience from influenza. Some people do get some interstitial lung disease. We don't know yet with COVID, but our antennae are certainly very up. So summary and conclusions, and I've underlined, bold, and emboldened the bits I really want you to take home. First, the narrative of COPD has changed. Up to 45% of COPD occurs in non-smokers, particularly in the developing world. It's a different phenotype, and it's very important. And as I said before, I think this respectabilizes COPD to being a disease like ischemic heart disease and hypertension. It is not all self-inflicted cigarette smoke. That's all we've been focusing on up to now. So in a sense, this is a new disease I'm introducing to you today, of which one phenotype is people who smoke heavily. But it's not the only phenotype of patients with COPD. There is now increasing and will be increased focus on early detection and intervention in patients with pre or early COPD. And this really, essentially, we're talking about screening. We're talking about increasing the penetrance of professional questionnaire into the community and the use of spirometry, annual spirometry, at a much greater frequency than we're currently using. It cannot just be a hospital It cannot just be a hospital procedure. It has to be carried out as part of screening for pre and early COPD. And if we do this, the gain is great, because currently patients with COPD, with the highest, we're only managing COPD very late in the stage of their disease when they exacerbate, i.e. we're treating the myocardial infarction, but we're not treating the high cholesterol 30 years beforehand. That's where we're at with COPD. But we in the respiratory community have now made that huge leap away from the distracting but very important cigarette-induced COPD. We are now, because of the prevalence in non-smokers, we are now focusing, there's going to be increasing focus on early or pre-COPD. There's a huge unmet need in COPD in terms of symptoms, exacerbations, and mortality is linked to COPD severity. Dual therapy is better than mono. It deflates the preload and it bronchodilates the afterload. Triple therapy is more effective than dual bronchodilating therapy in symptomatic exacerbating patients with COPD with a good BMI, whose eosinophils are greater than 100 cells per microliter, who don't have purulent sputum and don't have something else going on, and who don't have asthma, as we've outlined. The benefit of inhaled corticosteroids on exacerbation reduction, in my view, vastly outweighs the risk of community-acquired pneumonia, because it reduces exacerbations, it reduces all-cause mortality, and even in the small population who get increased community-acquired pneumonia, they don't die from same statistically. COVID has focused our mind on the remote consultation and therefore the core consultation in COPD, which is history. Are they A, B, C, or D? Put them on the right treatment, get your chest x-ray, your full blood count, and reassess. So thank you very much.
Thank you, Stephen, for that excellent presentation. I remember Stephen a couple of years, 2 or 3 years ahead of me. He had an excellent head of hair then, and he's got an excellent head of hair now. So I'm somebody who is follicularly challenged. That's sort of something to note. We have a number of questions who have come in from our participants, but I'd like to first apologise for the delay in leaving our panellists in. They've been very patient in waiting for the presentation to finish. In the environment we're in, where unfortunately anybody has to be presumed to have COVID to a certain extent, and we're very much triaging consultations into general practice, and in the context that we've just started a new chronic care contract with the HSE, I was going to ask Stephen to kick off with how we can assess somebody by telemedicine, some of which is already being done by the respiratory departments in the hospital, how we can assess somebody by telemedicine on whether we need to change your treatment, or equally, in the absence that we're going to be doing spirometry in a general practice setting, if we're able to bring the patient in to a consultation, how we can assess them, some of which he's alluded to already, but how we can assess them on a brief consultation. What most of us try to do is limit our consultation to 5-10 minutes in assessing them in the surgery setting. Whilst we're considering that, another question that's come in is that recognising that the prevalence of smoking is going down, and it's something I've got an interest in myself, do we envisage with the prevalence of cannabis in our young population, do we envisage the mixing of cannabis with cigarettes as something which is going to affect spirometry in the future? Is it something that we should be considering as general practitioners? Has that any influence of any of that?
Thanks, Ray. It's difficult at the moment, okay, but if you have patients who have established.
I apologise. I think we're having some technical details, but we're trying to sort out here. I'm not too sure if I'm on the screen, but I'm going to add in another question. A frequent request to general practitioners, to many people who are on the modern inhalers, to many people who possibly are on steroids, or sorry, on mixed atropine and salbutamol nebulizers at home, is they like the benefit of their weekly.
I'm not coming in live there, just can you hear me now okay?
Yeah.
Hello?
Yes.
I can hear you, Stephen. I don't know whether you can hear me.
Can you see me or hear me there? Hello?
Presently on my screen I can see me, but I can't see start my video. Can you hear me, Stephen? Apologies if we're having some technical difficulties here again. Can you hear us, Stephen? It appears you are on the main screen, Stephen, so if you can continue to talk, if you can hear. I can't hear you.
Okay, sorry, I'm going onto my phone here. Can you hear me now, see me now?
I can see you and I can hear you, Stephen.
I can hear you, yes, I can hear you well.
Okay, so maybe you'd actually kick off with the question in regard to how a GP can provide a brief assessment either by phone or a very brief consultation in regard to assessing in the surgery setting. I've lost sound there on Stephen.
There's just a delay.
Okay, can you hear me now?
I can hear you. Go ahead, Stephen.
Well, in regards to the remote consultation,
You're coming and going, Stephen. I don't know what's wrong with the sound.
okay, I think that if you've got a patient with established COPD, with diagnostic spirometry, I think it is easy to get us either do a CAT score or an MRC score over the phone. Yeah, sorry about that. I'm here. I can hear you guys okay. Hello?
Yes, yeah.
Hello?
We can hear you, Stephen.
Hello?
I can hear you, Stephen. Continue talking, Stephen.
Maybe if I just did it on the phone. Can you hear me here, Ray?
I can hear you, Stephen.
Okay, I'm coming out of the computer now and I'm going to leave the meeting.
Do we want to go to the next speaker?
We'll try and come back to it.
Yeah.
Not yet, it was a few minutes.
the screen to everybody now?
Yeah, yes.
Okay.
We're going to the next.
Okay, I think it'll be indicated to me whether we're going to go to the next speaker or not. At the moment, it appears we have technical problems. I'll just give you the context of how this is organised by Menarini. I'm in Crow Park Hotel, and the recordings were done on individuals in the past, including Francis, and the aim was that we would connect people by televideo from where they are. Unfortunately, the technology, as we all know in general practice, sometimes computers go down or whatever, but they're gremlins. So it is likely we're going to go to the next speaker, and we may get a chance to come back to Stephen again. The next speaker will be Professor Ivan Casselry. Ivan is a cardiologist in the mater public and the mater private, originally from National University Galway, NUI Galway. He's trained in the US, Cleveland Clinic. He has an interventional cardiology fellowship from Barnes Jewish Hospital, St. Louis, Minnesota. He's trained in advanced interventional cardiology fellowship from Cleveland. Prior positions were cardiologist Denver, cardiologist Colorado, and our topic is updating the management of stable coronary artery disease, all very relevant to us. Thank you.
Thank you very much for the invitation to give this talk today, albeit virtual. The topic that I was asked to talk about was stable coronary disease, which is timely because the guidelines for the management and diagnosis of chronic coronary syndromes was just published this year. In addition, there was a large randomized trial, probably the largest randomized trial of revascularization in the setting of stable coronary disease, just published this year, the ischemia trial, which gained a lot of attention, and there were actually 4 separate publications in the New England Journal of Medicine in April and May covering different aspects of this patient population and this question. So I think it's not a bad time to talk about that in the context of the recent guidelines. So just to start, I just wanted to talk a little bit about the pathophysiology of atherosclerosis, just to recap and get everybody on the same page. I think it's important to understand that atherosclerosis is probably set up from the first decade of life. In postmortems of American people from the army in the Vietnam War, when they took the teenagers who died and they did autopsies, they actually found fatty streaks in the intima, which are the precursor to atheroma later in life. So that's a sobering thought as you feed your children fast food, etc., that we're setting them up for atherosclerosis later in life. So based on the background of that fatty plaque, in the second and third decade of life, we begin to form these mature atheroma, which is accumulations of fat with a fibrous cap. And in our fourth, fifth, sixth decade of life, we begin to get the complications of atherosclerosis. Now, initially, when atheroma develops in the wall of the artery, there's an expansion of the elastic membrane so that the plaque can accumulate without compromising the lumen. But in the fourth or fifth decade of life, that positive remodeling of the artery no longer compensates, and the plaque begins to compromise the lumen, causing stenosis, and the patient then can get ischemia with exercise, which is the substrate for stable angina. In a subset of those patients, we get atherothrombotic complications where there's a fracture or an erosion of the fibrous cap, and we can acutely or subacutely develop clot, getting an acute coronary syndrome, which can manifest as unstable angina, a non-ST elevation MI, or an ST elevation MI. So we're going to concentrate today on the patients who have stable coronary artery disease. They do not have atherothrombosis, and I think that's very important because these entities are quite distinct. Their prognosis is quite distinct, and the management is distinct, particularly with respect to revascularization. The aim in managing somebody with stable coronary artery disease is to try to keep their prognosis as close as possible to somebody who doesn't have atherosclerosis. Now, we know that patients who have stable coronary disease, some patients will have a fairly benign course and may never have an acute coronary syndrome in life. Other people may have one or more acute coronary syndromes and may have one or more revascularizations. We do know that the better we manage their risk factors, the better they adhere to a healthy lifestyle with good diet and exercise, and with appropriate revascularization, we can try to get their prognosis similar to somebody who doesn't have a diagnosis of coronary disease. And that's really what we're going to talk about today. So I thought it might be helpful just to keep two patients in mind. These are patients that we often get referrals to clinics for. But the first patient is a fairly straightforward case, 75-year-old man, a couple of risk factors, and he has typical angina. Second patient is a patient we often get asked to see as well, a female who's 35, who has one risk factor and has a random discomfort that is concerning to her and perhaps to her GP. So how do we approach that patient? Well, this is what the guidelines tell us we should do. First thing is we should assess the symptoms. Second thing is we look at their comorbidities. We may do some tests. We assess the likelihood that they might have coronary disease. And then we may or may not do a diagnostic test, and we'll talk about that. And then finally we come up with what the appropriate therapy is like. So the first thing, assessing the symptoms, and this is something that's really, really fundamental. And it's something that I spend a lot of time teaching the junior doctors, that they really assign the chest pain syndrome to either being a typical angina, atypical angina, or non-angina, because this really determines how you're going to manage the patient. Angina is discomfort in the chest, neck, jaw, or shoulder that patients typically describe as a tightness, a pressure, a heaviness, a discomfort. They'll often say specifically, it's not a pain, doctor, it's a discomfort. It's predictably brought on by exertion. And in general, the amount of exertion that brings it on is fairly predictable. They won't be able to walk 3 miles one day and 100 yards the next day. So it's a predictable amount of exertion, assuming that other conditions are fairly stable. And it's relieved by rest or by nitrates. The pain tends to last for minutes, not seconds. And when they rest or take their nitrate, it should be gone in 5 minutes. So a pain that persists for an hour is not angina. If you have all three, that's what we call typical angina. If you have two, it's called atypical angina. If you have none or one, it's non-cardiac chest pain. The grading is according to the Canadian Cardiovascular Society classification. So grade 1 is with strenuous exercise, grade 4 is angina at rest. So what I like the junior doctors, when they come to me, I'd like them to say, I saw this patient in clinic, they have typical angina, they have CCS grade 2. And it would be great if we all got on that kind of page in terms of when you're referring patients to describe what kind of chest pain they have, and if they have angina, what grade it is, because that helps us screen the patients in clinic. Very important to go over their risk factors, and this is an opportunity to kind of review the risk factors of the patients, the traditional risk factors of diabetes, hypertension, smoking, and lipids, and then comorbid conditions that might influence your management. On exam, I focus a lot on BMI. A lot of our patients today are overweight and don't recognize that they're overweight, and that influences the management and also influences their symptoms. Measurement of blood pressure, assessment of heart rate and rhythm, trying to pick up valvular heart disease that might interact with coronary disease, and a vascular exam, carotid bruit, peripheral pulse exam, because peripheral artery disease will often go along with the diagnosis of coronary disease. An ECG is fundamental, very important. If it's normal, it's very helpful in terms of predicting that the LV function is probably normal. Routine labs should include a blood count. Occult anemia can be a cause of angina sometimes. Renal dysfunction is important because if we're going to do tests that involve dye, it's important to know what the creatinine is. A fasting lipid profile, very important in terms of your risk factor. A fasting glucose and hemoglobin in A1C, we have a lot of undiagnosed diabetes out there. And TFTs if you think there might be a problem with thyroid function. An echo is important if you hear a murmur or if you have concern that the patient may have heart failure. So with that clinical assessment of their symptoms and comorbidities, the guidelines tell us that we should try and make some assessment of what we think the pretest probability of the patient having obstructive coronary disease is. And if we take the patient A, our 70-year-old patient, male, who has typical angina, that patient has a 52% chance of having obstructive coronary disease. It's fairly straightforward what we need to do with that patient. We need to do an angiogram and assess their coronary anatomy. Whereas our female patient with non-cardiac chest pain, who's 35, has a 1% chance pretest probability of having obstructive coronary disease. That's very, very low. That patient doesn't need any further testing. What they need is assessment of the risk factors and management of the risk factors moving forward. And that's kind of illustrated here in step 5. If your risk of having obstructive coronary disease is very low, what you do is assess their risk factors and manage them. If their risk is very high, they almost certainly need an invasive angiogram to assess for coronary disease. It's the group in the middle that tend to get the testing. So the people who have pretest probabilities around 15%. In general, what's recommended is that if you think the patient doesn't have coronary disease, CTA is probably the best test because it has very good negative predictive value. So it's very good at saying if the coronaries are clean, it's very good at saying that they're clean. The more likely you think they have coronary disease, a functional test is probably the better test because it's a little bit more specific and it's a little bit more sensitive. So this is what your CT coronary angiogram looks like, and we get 2 pieces of information from CT coronary angiogram. We get their coronary calcium score, which has a prognostic impact, and we get anatomic detail. One of the problems with CT coronary angiogram is that if you have a lot of calcification, it can make interpretation of the lumen quite difficult. So patients who have a very significant smoking history, they tend to be problematic because the calcification that tends to occur in those patients, and also diabetics, can make interpretation of the lumen difficult. But CT coronary angiogram has evolved very significantly. I would say maybe 4 to 5% of patients now have an uninterpretable CT scan that we end up having to do an angiogram because the calcification gets in the way. But it's a very good screening test for somebody who you think is normal and that you just want confirmation of it. So this tends to be often young patient, very bad family history, and they want certainty that they don't have at least the anatomic substrate of their relative. These are the functional tests that we use. In Ireland, I've circled the ones that we typically use: stress echo, stress ECG, dobutamine echo, and adenosine MRI. That probably constitutes 99% of the stress testing, that's functional testing that's done in Ireland. You can see the stress ECG is not very sensitive, but it is quite specific. So if it's abnormal, it's very likely the patient has coronary disease. The other tests, the stress echo, dobutamine echo, and stress MRI, they're more sensitive, but not necessarily, but more specific than a stress ECG. So which test you do often depends on your own personal bias, the local expertise. Some centres are very good at stress MRI, some centres are very good at stress echo, etc. So depending on the preference of the cardiologist and the expertise, they may choose one particular stress test over another. So having made the diagnosis of stable coronary disease through the non-invasive test or your invasive test, we then have two goals. One is we want to reduce their risk of a major adverse cardiovascular event, and if they have symptoms, we want to treat their angina. So the first is what's often forgotten is that patients who have stable coronary artery disease, they have an ongoing risk of cardiovascular death, MI, and stroke, independent of this coronary artery disease diagnosis. Depending on which population you study, the risk of those events can be 3 to 5% per year. So it's very important that in addition to treating the coronary disease, that we also address these events. And the way to do that is the kind of holistic approach to the patient. Managing risk factors. If the patient smokes, they must try to quit, and we must try to help them. If they have high blood pressure, we should treat it aggressively, and if they have documented coronary disease, ACE inhibitors or angiotensin II inhibitors should be favoured. If they have, we should aggressively treat their cholesterol, and the goal LDL should be now 1.4 in the recent guidelines. So we should do that with statins, and if we can't get it done with statins, then we should add ezetimibe. And when the PCSK9 inhibitors become available, those will also be an option for patients who are statin intolerant or where we can't get them to target. Right now, they're very limited availability based on quite strict rules from the HSE. Diabetes should be managed aggressively with the goal of keeping the hemoglobin A1C at least less than 8%. We need good diet, and I listed on the top, it's a very difficult, I think in a GP practice and even in a cardiology practice, it would be much nicer if we had better dietitian support to help us with guiding patients through diet. Patients are very confused about diet today. I really just try to get them to eliminate high calorie, high sugar products in their diet. Try to eat as much fresh fruit and veg as possible, and try to get them to restrict their calories a little bit. Most people are probably eating too much. Exercise is important. They should be exercising 30 minutes at least 5 times a week. And then after that in terms of blood thinners, everybody should be on an aspirin. If they're intolerant of aspirin, they should get Plavix. If they can't tolerate Plavix, and that's usually because they have a rash. Rivaroxaban was tested recently in a trial, and there's some suggestion that in high-risk patients it may be a benefit. I personally tend to reserve it for patients who maybe have a stable coronary syndrome, who now begin to develop acute coronary syndromes that are despite intensive medical therapy. And then the last therapy here is a beta blocker, certainly for patients who have stable coronary disease and LV dysfunction. That should be used. For patients who have had a recent MI within the last year, it's reasonable. Beyond a year, the data is becoming a little bit more equivocal as to whether all these patients should be on a beta blocker. In terms of relief of angina, there are a lot of medicines available, and these are the main ones that are listed here. I think in the recent guidelines, they divided them into first-line and second-line agents. So the first-line agents are beta blockers, non-dihydropyridine calcium channel blockers, and dihydropyridine calcium channel blockers. The second-line agents that will be used in Ireland will be long-acting nitrates, ivabradine, and ranolazine. So these are the class 1 agents. Short-acting nitrates. Side effects include, main side effect is headache. Sometimes you can get a reflex tachycardia. Just be careful not to use these in people with hypertrophic cardiomyopathy, or if they're taking phosphodiesterase inhibitors. These will be usually drugs for erectile dysfunction. You might have some patients with primary pulmonary hypertension on those agents as well. Beta blockers, I would say in Ireland, are probably the most common first-line agents used. They're fairly effective. You just have to watch out for heart rate in patients who have AV nodal disease, and avoid combining them with the non-dihydropyridine calcium channel blockers, because you may get excessive bradycardia. Patients with COPD also may not tolerate beta blockers well. The calcium channel blockers, as we said, are divided into 2. The non-dihydropyridine ones, which is verapamil and diltiazem. They have sort of the same side effect profile as the beta blockers, although they're better tolerated, obviously, in patients with COPD. And then the dihydropyridine calcium channel blockers, such as long-acting nifedipine, lercanidipine, amlodipine, they're effective, and the main side effect is lower extremity edema. So that's often what you get called about with that drug. I've just shown this slide to show that there's actually some disparity between the grade of recommendation of these drugs according to the ESC and the American guidelines. So there is some variation geographically between Europe and the US, but this is the European recommendations of how we should use these agents for the treatment of angina. So we should start with either a beta blocker or a calcium channel blocker. If they still have symptoms, we should add a dihydropyridine calcium channel blocker to the beta blocker. And then you can add your second-line agents, which would be a long-acting nitrate, as I said, ivabradine or ranolazine. If somebody has a high heart rate, the beta blockers are helpful, as are the non-dihydropyridine calcium channel blockers. Ivabradine may have a particular use in those patients. For patients with low blood pressure or low heart rate, ranolazine may have an advantage there because it's fairly neutral For patients with low blood pressure, ivabradine may have an advantage because it has a fairly neutral effect on blood pressure. And just to go over those two second-line agents, because we tend not to use them that much, but ranolazine, it's an inhibitor of late inward sodium channel. The dosage is 375 to 750. It has a neutral effect on heart rate and blood pressure, which can be helpful in patients where that's an issue. It does prolong the QT interval. You've got to be a little bit careful in patients with renal insufficiency. You probably shouldn't be using it in patients with GFRs less than 30 for sure. It's a helpful agent in some patients. Ivabradine, also a second-line agent, blocks the what's called the funny channel. These are sodium potassium currents in the pacemaker cell in the SA node. The dosage is 5 to 7.5 twice a day. And again, useful in patients who can't tolerate a beta blocker and have a high heart rate, or patients who have low blood pressure. So what about revascularization for stable coronary disease? Balloons and stents have been around a long time, and drug-eluting stents have been around now for going on about 15, 16 years. Very effective at treating blockages, and when you do these procedures, you get very satisfactory results. So this is a patient with a blocked right coronary artery, a couple of stents, looks good. This is a patient with a severe stenosis in the mid-LAD. After a stent, everything looks good. And it's hard not to believe that this isn't a great thing for patients with stable coronary disease. However, when tested in randomized trials, it's proven to be a little bit more complex, and the story isn't quite as straightforward. And the first trial that kind of made us challenge things here was the COURAGE trial. It was done in 2007. And they randomized patients to optimal medical therapy versus optimal medical therapy plus PCI. And they looked at death and MI as an outcome. You can see here it was a reasonably sized population, nearly about 2,500 patients, predominantly male. The majority were symptomatic, and a majority of them had 2 and 3 vessel coronary disease. But EF was preserved, so probably a lower risk group in that sense. What you see in this trial is that when you're in the setting of a randomized trial, optimal medical therapy really helps. And these patients, if you look at all the risk factors, they were very aggressively managed, probably better than we would achieve in real practice. And in addition, the adherence to medical therapy in terms of use of ACE inhibitors, statin and aspirin was very high. And in that setting of optimal medical therapy, they failed to show a benefit of stenting in terms of improving mortality or reducing the risk of MI. And this was very disappointing at the time for interventional cardiologists, and we scratched our heads. A subsequent meta-analysis of this trial plus others seemed to reinforce the same impression. So this is 5 trials looked at a meta-analysis looking at in patients with stable coronary disease, comparing optimal medical therapy versus PCI. And again, death unchanged, non-fatal MI no different, unplanned revasc trending in favor of PCI but not statistically significant. And even when you looked at the impact of PCI on angina here, it wasn't that different compared to medical therapy, and not statistically so. So people went back to the drawing board and they said, well, why doesn't stenting seem to help in patients with stable coronary disease? And one of the hypotheses put forward was that maybe we're not treating patients with a large enough ischemic burden. And this study was a retrospective study looking at patients treated with medicine versus PCI. And it seemed to be that the patients who had an ischemic burden over 10% of the myocardium seemed to do better with intervention versus medicine, hypothesis generating. In addition, it was felt that we probably don't accurately estimate the true severity of coronary disease by angiography, and that there are tools that we can use in the cath lab, such as pressure wires, to get a better handle on the true hemodynamic significance of coronary disease. And if we kind of identified patients where hemodynamically we objectively proved ischemia, that we might identify patients better who would benefit from revascularization. So this is what we call a fractional flow reserve, where we measure the mean pressure distal to the lesion and compare it with the mean pressure proximal to the lesion. And if that ratio is less than 0.8, we assume that the lesion is hemodynamically significant. And when they looked at randomized trials again using this technique in the cath lab to try to better define the patients who had true hemodynamically significant disease, what they found was that the FFR-guided patients seemed to do better with reduced death and MI, and this was statistically significant. This is a trial that was published in 2018 and got a lot of press. It was called the Orbiter trial, and it was the first trial where they did a sham procedure to control for the effect of patients having a PCI. So they took patients with coronary disease, proven by angiogram, and then they blinded the patient and anybody following up the patient to whether they actually got a PCI or not. Now, this trial got a lot of press, but it was a very small trial. It was only 200 patients. And the endpoint was not a clinical endpoint, it was exercise, your total exercise time. And while the exercise time was improved in the patients who got PCI, it wasn't statistically significant. But this got massive press, and this is just an editorial from the New York Times where they said heart stents are useless for most stable patients, and there were thousands of other editorials similar to this. So this led into the ischemia trial, which was supposed to kind of address all the shortcomings of these previous trials. And it was a very large trial with independent funding. It wasn't funded by any device company, so it was meant to kind of be objective. And they took patients who were pre-screened in a blinded fashion with a CT coronary angiogram to exclude patients who had left main coronary disease. And they were then randomized to medical therapy versus PCI and optimum medical therapy. And the plan was to follow them up for 3.5 years. And the study was published, as I said, in April 2020. So the primary endpoint they came on was cardiovascular death, MI, hospitalization for unstable angina, heart failure, or cardiac arrest. And for that endpoint, they found no difference between patients who got the PCI plus medical therapy versus medical therapy alone. And if you look at the individual components of the endpoint, death, MI, or cardiovascular death plus MI, there was similarly no difference. It did appear that patients who got the PCI had an early hazard from PCI-related MI, but over time, the risk of spontaneous MI seemed to be less, but they both balanced out so that in the end, the composite endpoint was neutral. If you looked at quality of life in terms of relief of angina, there did appear to be a benefit of PCI over medical therapy. However, the benefit was modest. So if you look at the Seattle Angina Questionnaire, the summary scores, which was the primary endpoint, it has a score of 0 to 100. You're talking about a difference of a score of 4 between the two groups. However, about a third of patients were asymptomatic, and it appeared that the greater benefit was in patients who had more frequent angina at baseline. They then took a separate group of patients who had stable coronary disease but also had significant chronic kidney disease, because these patients were systematically excluded from all the previous studies. Again, however, with the primary endpoint of death and MI, there was no difference between the patients who got PCI versus surgery. And in contrast to the other cohort, when you looked at quality of life, it wasn't that there was no significant difference. So very sobering data, to be honest, looking at the role of PCI in patients with stable coronary disease. And how I'd summarize it is that the role of revascularization for stable coronary disease, it's been hard to demonstrate an improvement in hard clinical endpoints like death and MI in randomized trials. I think any potential benefit is probably limited to higher risk patients, patients with severe ischemia, multivessel disease, left main, proximal LAD disease, and patients with LV dysfunction due to multivessel disease. In relief of angina, PCI is probably a bit better than medical therapy. However, I think we probably exaggerated the magnitude of the benefit with PCI and probably underestimated the magnitude of the benefit with medical therapy. And for patients with chronic kidney disease, I think we need to be very careful subjecting these patients to PCI in the setting of stable coronary disease. Decisions need to be made by multidisciplinary groups. So in summary, stable coronary disease is an important entity, and its management is very distinct to acute coronary syndromes. The medical therapy should focus in a very holistic way on lifestyle, with emphasis on diet and exercise, prevention of adverse cardiovascular events by aggressively modifying risk factors on a background of antiplatelet monotherapy and aggressive treatment with statins with a target LDL of 1.4. In relief of ischemia, our first-line agents are beta blockers and calcium channel blockers. Our second-line agents are long-acting nitrates, ranolazine and ivabradine. In terms of revascularization for stable coronary disease, I think it's reasonable for high-risk patients, for patients where we can't manage their symptoms with medications or where patients are intolerant to medications, and revascularization should always be as part of a complement to optimal medical therapy. Thanks.
Thank you very much, Ivan. That was excellent. Hopefully our technology is going to allow us bring into our chat room Stephen and Ivan. Maybe Stephen will come online there. Now, just to explain to people, at wherever you are, there tends to be a 15-minute delay. So hopefully those 15 seconds, not 15 minutes. God, that'd be a good one. Hopefully that will come online now. So we're admitting into the chat room. So I can see Stephen, and hopefully Stephen can hear me. And you want to speak there, Stephen?
Phase of this disease, so we'll go on. We'd hope it to end.
Recognizing there's a 15-second delay. So I can see Stephen. Can you hear me, Stephen?
Hello, I'm here.
Okay, you're live, Stephen. I can hear you. Go ahead if you want to allude to some of the questions. Apologies for all the difficulties with the IT. So go ahead, please. So we were going to allude to questions in regard to recognizing there's a new...
Yes, hello, Stephen Lane here.
Hi, Ivan Cassidy here.
Hi, I've just listened to your talk. Very good. That came across very well.
So if you want to allude to, we have a new contract coming in with the HSE in regard to chronic care, including asthma and COPD, Stephen. And part of that will be assessing people by televideo. Part of that will be bringing people in, but we have to be cognizant that if we bring people in, we will shorten the duration of consultation. We won't necessarily have access to spirometry in the practice, and nationally for GPs presently there is a inaccessible access to spirometry. So really, can you just do what GPs, or give us some guidance in regard to how that assessment should occur?
Are there any questions coming through? Or?
No, not yet. We had problems after my session, and they were going to defer the Q&A until after your talk. Do your Q&A as well at this time. I see Ray is unmuted, and you're unmuted, but I can't hear anything coming from Ray yet.
That won't allow me unmute there, but the...
Maybe all we can do is wait.
So they won't allow me unmute here, guys. Yeah,
They told me that what was happening was that the live stream was cancelling out the Q&A on the panelists. So
Yeah, they called me and I was trying to turn my...
can that work on battery?
yeah.
And of course, this is a massive magnification. This is a
I have to admit, I did not appreciate that 45% of CPD was on multiple relations.
Yeah,
down, fancy American term.
Can I take that off part? Okay, right. Okay, so we're now using two laptops, so apologies for that. So Stephen, there's an echo on this, so we can get rid of the echo if possible. Anyway, Stephen, in the context that we have a new contract which is live with the HSE, and in the new environment of COVID, our contract does allow a telemedicine component where we assess people, but equally, we're very aware that if we have somebody who is well And we're very aware of the morbidity issues with not assessing the elderly in regard to their mental health and not being able to give some guidance in regard to other things. We'd like to bring some people in who are COVID asymptomatic, but we are very obviously aware that consultations need to be brief. We won't have access to spirometry either in the practice. At the moment, nationally, we don't have access to those diagnostics anyway. So could you just give us some guidance recognising that context?
Yeah, well, I think in the context of COVID, I mean, if you've got a patient with established COPD, the matter is fairly straightforward. It's a question of asking them on their current therapy if they're breathless, if their breathlessness is improved, or not worth using a CAT-score MRC, or just simply asking them, are you more or less breathless? And whether or not they're exacerbating, you know what that means. And if their stage of COPD is stepped up, well, then step up the treatment, and if their stage of COPD
You see here, there's the
you would step down, and their treatment just healing, you would step up or step down. The problem arises when you've got a new potential diagnosis of COPD in context, and you can ask questions. The concern is that you might be missing something. You really need your chest X-ray, and that's really important because you may be missing a lung cancer or further diagnosis. There's really no way around that. Overall, in terms of when this pandemic is over, or normal, the focus is shifting back from the 60-year-old end-stage disease that is part of our universe now, and shifting back to pre-COPD, any symptoms with no spirometric abnormalities, and early COPD with symptoms and/or and spirometric.
Guys, any way we can crash that sound? Yeah.
COPD management going forward, because we are only currently dealing with patients with end-stage disease, and we need to shift backwards 20, 30 years.
Which one is that? That one. Okay, that's very helpful. Thank you very much. Listening to your presentation there was actually quite interesting that the effect of environmental hazards in other countries, and thankfully we don't have that. But one of the questions that did come in by our link was in regards to, we have a young population who are actually, cannabis is on the increase in many young population, and they mix it with tobacco. Is that something which, and I know the American Lung Association raised concerns in regard to the potential carcinogenic effects of cannabis. Is that something that you see anything of in your setting in Tala?
Well, as I said, the whole narrative has changed. I mean, in one of those studies of COPD and non-smokers included Ireland, reference 20 of that. 20-25% of people in Ireland with COPD with no history of smoking. And of course, what has to think then in that context about, turf, about the smoking in context. There's a very good program with T.G. Taher during the week highlighting those issues, the coal burning, all of that type of stuff, and certainly and absolutely smoking, cannabis with or without cigarettes, vaping, all of these, we are now, the whole narrative of COPD is shifting to not just increase heavy smokers, and young people now who are smoking cannabis or vaping are certainly putting themselves at risk. I mean, the smokeless coal and the ban of cigarettes, Professor Nancy would send it to in our profession, has made an enormous difference, I would imagine, and we'll see that difference. So in answer to your question, absolutely, without a doubt, it fits into the model narrative that people smoking cannabis of early COPD. And studies, people should do studies of these patients to see are there any, just a symptom questionnaire, very simple questionnaire, and FEV1, just simple spirometry and a questionnaire to look specifically at that group of people. It'd be a very interesting study to do.
Okay, I'm going to bring in Ivan now in regard to COVID, and we're reading, especially from the US, an indication that there are cardiovascular ailments associated with COVID, especially myocarditis. Maybe he could allude to that and just talk us through what he's seeing in the matter and what is coming in internationally.
Yeah, so there's no doubt there is a myocardial issue with COVID. syndrome, we are seeing a post-COVID myocardial syndrome where patients have had a mild myocarditis clinically at the time of the COVID presentation, and then seem to have a prolonged chest pain syndrome for several months afterwards. And there's a little bit of an interaction with, they have some shortness of breath, but it's dominated by a chest pain syndrome without objective findings, or very minimal objective findings on cardiac MR or CT in the lungs. So, so our experience is that it's a small, in terms of magnitude of issue, small. In the Italian experience, they've reported some autopsies. Again, it's very hard to know what the numerator and the denominator for these kind of studies are. They've shown some quite significant myocardial damage in autopsy studies. I think COVID in Italy was worse than COVID in Ireland, and their experience was worse from a cardiac standpoint. So I think it's going to. I think the answer is that we don't know. I think geography probably matters, and fortunately in Ireland, I think our cardiac impact has been small, and hopefully will remain that way.
Okay. In that, Ivan, do inflammatory markers tend to be elevated in those circumstances?
Not really, no. You know, it's troponins and edema on the MR. That's usually what we're seeing in the diagnosis of it.
Okay. So fair to say, if you're suspicious of it, did make your decisions on a clinical basis, though, not necessarily on the basis of whatever investigations come back if you're attending the GP?
Yeah.
Okay.
And I think a high sensitivity troponin is certainly your best diagnostic marker of it. Although one patient, the troponin was normal, a lot of symptoms, and it was an MR finding. So even without the troponin, if the symptom complex is dramatic with the COVID diagnosis, I think the antenna should be up, and that maybe, unfortunately, in terms of resources, it's a lot. But if somebody has a very dominant chest pain syndrome plus COVID, I think we're probably going to end up doing a cardiac MRI.
Okay. Going back to the normal mundane cardiology, one of the things we're going to be asked to fill out as part of our, again, new chronic care contract, which covers vascular disease, including ischemic heart disease, major stroke, minor stroke, TIA, atrial fibrillation, is a Q risk analysis. Are you familiar with Q risk analysis, or is there any risk analysis that you guys use in the cardiology setting?
Yeah, so that's an interesting question. In actual fact, in preparing for the talk, I looked at the ESC guidelines. Actually use what's called a score, and it's actually quite crude, and it's just age, gender, and cholesterol, which is a very crude kind of, there's 3 parameters. The Q score is, I think, probably the best. It's actually much more detailed even than the Framingham score that's used in the US. So it includes a lot more variables, and it's tested in the UK population. So I think in the Irish context, I think the Q score probably is what we should be using, but it does require, you've got to measure the height and weight, you've got to have the full lipid profile. It takes a little bit more energy than the ESC score or even the Framingham score. But I think in the Irish context, that's what we should be using, and that's what we should be using to assess risk. And the Q score has given us 10-year risk of stroke and death. So my feeling is, patients who have a score of less than 10%, that's less than 1% per year, that's a low risk group. And really we should be managing those patients with, referring that kind of a patient who has no symptoms, a good exercise tolerance. I think what really needs to happen is just manage the risk factors locally. If somebody has a high risk, that would be the patients over 20%, then those patients it's reasonable to get a cardiology referral. The intermediate risk, again, I think if they've got good exercise tolerance, it's about managing the risk factors.
Okay.
So I think we'd love actually if every referral for coronary artery disease evaluation came with a full Q-risk score, and the variables that went into that score were provided in the referral, and the national referral form. It'd be great to get that in there for cardiac referrals.
Okay. In regard to that, like obviously we're trying to manage the variables. You can't obviously change people's genetic inheritance. You can't change their past medical history. So your normal blood pressure, you've tried to get their weight down, and the only risk factor then you're left with, which is the indicating is the cholesterol, and it's putting you between 10 and 20. Should we be starting a statin if that is the only variable we can manage?
Yeah, it's a tough question, and I think that's where, if you have an intermediate risk patient, bad family history, then maybe you kind of get more aggressive with it. I think that's where you go case by case, and that's where maybe a test like a coronary calcium score might help, because it might, if your coronary calcium score is 0,
I'm going to go to the next talk after this.
Then maybe you leave that patient alone and just get them to work, diet and exercise. Where if you're intermediate risk and your calcium score is high, then I would lower the threshold for.
This is the last question.
The problem in the public system is, availability for coronary calcium scores. I mean, we should have much greater availability for that test, but our availability is quite poor.
Okay. Apologies if I'm talking over any of the speakers. At the moment, I'm managing 2 videos at the moment and 2 cameras in front of me. It's certainly a surreal experience for me, but thankfully, hopefully the gremlins. So what I'm going to do is I'm going to release Stephen and Ivan. I'm going to thank them very much for their informative talks. I think they're excellent. Thank you very much. And I'm going to go on to our 3rd speaker. So you guys are released for the rest of the day. Thank you very much.
Thank you, Ray. Thank you very much.
Cheers. So our next speaker is Luke O'Neill. Luke is Professor of Biochemistry in Trinity. He is the Professor of Biochemistry, Immunology, Biomedical Sciences at Trinity College. His main research interests include toll-like receptors, inflammasomes, and the immunometabolism. He will be known to most people, although not general practitioners, because we've been tolling hard through COVID, and I'm afraid listening to Pat Kenny in the morning is a luxury that I don't get to do, but he has a weekly slot on the Pat Kenny show on News Talk. Latterly, people might have been aware that he was had a publication, a book out in 2018 with Gill, the best-selling Humanology, a Scientist's Guide to Our Amazing Existence. And I gather he will have another book out in October for our kids, 10, 12-year-olds. That'll be a publication with Gill on the Great Irish Science Book. So hopefully I'm going to pass over to Luke. And good morning, Luke. So there will be a short commercial presentation from Menarini. There's again a delayed feedback or feed on this of 15 seconds. So that'll be coming through now in the next few minutes. Thank you.
Good morning, everybody, and many thanks for attending our virtual meeting this morning. My name is Keith Dara. I've worked with Menarini Pharmaceuticals as a medical representative for a number of years, covering South Dublin, Wicklow, Wexford and Waterford. I'd like to briefly talk to you about 3 of our key products. That's Brimica Genuar, Eclaira Genuar for COPD, and also Renexa for stable angina. Firstly, Brimica and Eclaira. Eclaira is our LAMA, a long-acting muscarinic antagonist indicated for maintenance bronchodilation treatment to relieve symptoms of COPD in adult patients. Eclaira can be used in initial treatment as per GOLD and ICGP guidelines, or as a treatment in combination with ICS and LABA. Brimika is a LAMA-LABA combination. That's a long-acting muscarinic antagonist and a long-acting beta-2 agonist, indicated for maintenance bronchodilation treatment to relieve symptoms in adult patients with COPD. Brimika can be used in a step-up situation from a LAMA or a LABA monotherapy, or switching from a LABA ICS or another LAMA-LABA treatment where appropriate, as per the GOLD and ICGP guidelines. Both Brimika and Eclaira are delivered via the Genuair inhaler, which is pre-filled and ready to use, is the only pre-filled inhaler which has a visual and audible feedback for confirmation of dose delivery, has a trigger threshold mechanism to prevent accidental double dosing. It also has a lockout mechanism to prevent further use once last dose is delivered, and works as follows. So the Genuair device works as follows. Hold the inhaler horizontally and press the button all the way down. The control window should change from red to green, then release the button. Hold the inhaler away from your mouth and breathe out completely. Never breathe out into the inhaler. Put the mouthpiece between your lips and close your lips tightly around it. Take a strong, deep breath through your mouth. A click will let you know that you are inhaling correctly. Keep breathing in as long as possible after you hear the click. Use the control window to ensure you have inhaled correctly. The window has now gone back to red. In summary, both Brimika and Eclaira provide significant improvement in early morning and nighttime symptoms versus placebo for COPD patients. Provide a twice daily dosing, that's one in the morning, one at night, are delivered via a simple to use inhaler. Brimika has the added benefit of containing the fast acting LABA formoterol and provides rapid bronchodilation within 5 minutes that is sustained and clinically meaningful. Please refer to the SMPCs for full prescribing information at medicines.ie. So as part of Menarini's cardiovascular range, we offer you Ranexa. Ranexa is indicated in adults as an add-on therapy for the symptomatic treatment of patients with stable angina pectoris who are inadequately controlled or intolerant to first-line anti-anginal treatments, such as beta blockers or calcium antagonists. Ranexa, or ranolazine, has many clinical benefits. Clinical studies have shown that Ranexa significantly improves exercise duration, significantly reduces anginal attacks and nitrate use. Ranexa does not significantly affect heart rate, nor does it significantly affect blood pressure, and is generally well tolerated. Ranexa is available in 3 formulations: 375 mg BD, 500 mg BD and 750 mg BD. 375 mg BD is a recommended initiation dose, and it is recommended this should be titrated up to the 500 mg BD after 2 to 4 weeks. Should it be required according to patient response, this can be further titrated up to the 750 mg BD, which is the maximum dose. On this slide, the contraindications for Ranexa can be seen. On behalf of Menarini, I'd like to thank you for your time and your support, and thank you again for attending our meeting today. For full prescribing information on Brimika, Eclaira and Ranexa, please visit medicines.ie or refer to the SMPCs. Thank you.
Thank you to Keith Dara from Menarini for that. The next speaker is Luke O'Neill, and I'm going to read Luke's bio. He's Professor of Biochemistry, School of Biochemistry and Immunology, Trinity. His main research interests include toll-like receptors, inflammasomes, and immunometabolism. He would be more recently known for his regular slot on News Talk. However, I'll explain to Luke, many GPs, if not all GPs, will not be aware of that because we're working very hard in COVID times, and luxury of watching and listening to Luke at 9 o'clock in the morning is not something we've had the benefit of. He has a radio regular slot. He's also well known for the fact that he published a book in October in 2018, best-selling Humanology, A Scientist's Guide to Our Amazing Existence. He has another book for 10 to 12-year-olds due out in October with Gill on the Great Irish Science Book. So I'm going to pass you over to Professor Luke O'Neill. Thank you.
So I'm Luke O'Neill, and I'm very happy to give you an update on COVID-19. I'm going to cover several topics in the next 45 minutes or so. Obviously, this is a fantastically important area. Very exciting research is happening in science, and the big hope is, of course, we might get to a vaccine or new treatments. I'm going to cover that as well. So obviously, it's the disease of the moment, as you'd all be very well aware. Many challenges. I would guess we're at the first phase of this disease, so we'll go on. We'd hope it to end, of course, as soon as possible, but it's a long vista ahead of us in many ways. I think one positive bottom line that we'll head towards is there will be a vaccine eventually. The question is when. If there is one, it may not be perfect, but it'll have an effect. I think more importantly, we're going to see therapies, which will help the inflammatory process, as I'll mention. And then thirdly, there will be ways to use antibodies as a kind of a prophylactic to prevent disease or treat disease. My prediction is that'll be the first clinical impact will be these antibodies, and I'll give you that story as well. I'm also going to give you all the science behind the virus and how it was discovered and what we know about it. Now, as you'd all be aware, I guess there's this absolute frenzy at the moment. None of us have ever seen the like of this. I've worked on inflammatory diseases for the past 35 years. I've had collaborations with industry. I've had a big academic effort as well. And of course, there's been massive research on these things anyway. But the last, I guess, 7-8 months, massive collaboration, huge amount of effort. Every pharma company's involved, every small biotech and many academic labs. And I'm an immunologist, and my lab, beginning in February, began to work on COVID-19. Now, I'm not a virologist. My main interest is the inflammatory process. But the truth is this disease is an inflammatory condition. And we could apply some of our knowledge from the inflammatory events that happen, say, in sepsis, and I'd worked on gram-negative sepsis, for instance, into COVID-19 quite quickly. And that typifies many labs now. We all want to make a difference and make our research relevant, I guess. And of course, this frenzy involves vaccines, antibodies, you'll see here, antivirals and anti-inflammatories. They be the four main, I guess, weapons that we might use against this virus. And as I've said, there is hope that at least one of these has to work. I mean, the analogy I give often is it's like shots on goal, and you've got 150 players on the field now, something like that, all the trials that are happening in different approaches. So surely one of them is going to score a goal and treat this disease. Now, here's what the virus looks like. And of course, it's always worth knowing your enemy. It's a coronavirus, which means it has a kind of a crown around it, hence the name corona. You'll see here this yellow stuff are these spike proteins that surround the virus. And of course, this is a massive magnification. This is a 30 million-fold magnification, so that's how tiny this is. Who would have thought a thing as small as that would have caused such havoc in the world? And you'll all know the numbers. I mean, at one point, 1/3 of the world's population was put into quarantine. They used the word lockdown, fancy American term. That means quarantine, really. And as you all remember, back in April and May, 1/3 of the world was in lockdown, was in quarantine. 1.2 billion children were kept out of school, which is another tragedy for all kinds of reasons. Now, luckily enough, many kids are going back to school. Ireland, of course, at the moment, we've reopened our schools. In America, 6 out of 7 kids are still out of school. And the reason for that is the virus is running rampant in the community there. And that's our biggest worry, by the way, is what's called community spread, as you know. I mean, if it's in the community, it means you don't know where it is. You can't track people. It's just in the community as a whole. In America, many communities are full of this virus, and they can't put their kids back in school. In Ireland, our community transmission is quite low, so we could reopen the schools safely. And the same in many places across Europe. But the fact is, the fear we have now is the schools may have to close again if community spread goes up, and that's why the government are still maintaining all these restrictions. And then, of course, if you talk about the economy, trillions, they can't put a number on the economic impact of this virus, and that's got to be our big concern as well, because no world economy, massive negative effects there. And one reason for all this effort is not just about treating people who are sick or protecting people. It's to bring the economy back, and that's got to be in our minds as well, very much so. And then I've got a question mark here as well. It's a work in progress. This is a brand new virus. I mean, this has not been on the world before. It's only been around for 7 months. So there's many unknowns that we still need to find out. And in fact, I would guess, and it's difficult putting a number on this, we have about 20% of the knowledge at the moment. There's an awful lot yet to discover about this virus and how it affects our bodies and our immune system. So it's very much a work in progress. But as I say, there is hope. The knowledge we have now will be useful. Now, here's a cartoon of the virus. So you'll see here, there's the spike protein. Looks like a little little golf tees, I guess. That's the protein that's really important. That sticks into your immune cells and into your lung cells, into your heart cells, into your brain. That spike can go almost anywhere. And the reason why that's the case is it binds a thing called ACE2. ACE2 is the sort of the lock, if you like, that spike key goes into, and that opens and goes in and infects that cell. ACE2 is highly expressed in the lung, so the lung is the first tissue that we think about when it comes to COVID-2. It's a respiratory disease. You'll see here as well the membrane protein, M protein, a bit smaller. Now these are important, both M and S. That's what vaccines want to target really, because we can get antibodies to these. And if you make antibodies to those two proteins, you can stop the virus going in because the M is also needed. And that's what many of these vaccines are trying to do, is to drive antibodies to the spike or the M protein. A good analogy there is like blue tack, I suppose I use that sometimes. It's like blue tack will mask these, and then the virus can't get in, and that's how vaccines would work. Vaccines also bring out T cells, which I'll come back to. They're a bit different. What they do is they kill the cell that's infected. So the antibodies stop the virus getting in. If it gets in, T cells come along and kill the virally infected cell, and that means the virus can't divide, because as you know, viruses live inside cells, and it's like you're blowing up the house, I suppose, where the intruder is, and both T cells and antibodies are equally important for the immune response to this virus. Lots of studies coming out now on antibodies working in various ways, either to spike or M. Both seem to work equally well. Some evidence to spike is probably slightly better, but still we know a lot about this virus, so it's staggering in many ways that this was first reported in December. And now we know what it looks like. We know all the proteins. We know it's an RNA virus, which means the recipe to make virus is based on the RNA molecule, not DNA. It's an RNA virus, like flu is RNA as well. Huge amount of knowledge. The Chinese deserve credit because they released the information on this virus very quickly, and then immediately we could start working on it, and we could try to develop vaccines, and all the usual things could then happen as a result of the Chinese releasing all that information. Now, the big question is, where did it come from? And this is important for a number of reasons. First of all, we don't want it happening again. There's a risk of another one. If we know where this came from, we can maybe think about stopping the next one. It also tells us a bit about epidemiology and how it spreads and so on. And incredibly, this recent paper just came out, I think it was in Nature. They reckon the ancestral coronaviruses were there probably 1,000 years ago in circulation on the Earth. And it's descended from one of these ancestral viruses. They use clever what's called genomics to figure that out. And then there were two main SARS-CoV viruses. SARS-CoV itself at the top here, that caused the disease SARS, which was a severe disease. It was 10% mortality. Only 10,000 people had it though. And the fire was put out quite quickly with SARS. The main reason for that is you spread that one by having symptoms. So in other words, you could find the person with the symptoms and then isolate them and stop it spreading. The other member of this little subfamily is the SARS-CoV-2 subfamily, if you like. And lo and behold, we think that came from bats. And the closest relative to SARS-CoV-2 you see here is in a bat. So there was some ancestor that gave rise to these two, one for human, one for bat. And they're very close, I guess siblings is the way to put it. And that's where it came from. It jumped from bats into humans. It might have gone through pangolins, because they found one you'll see here in the pangolin as well. And maybe it went from the bat into the pangolin, and then the pangolin to humans, or maybe just from the pangolin. It's still not fully understood, but we're pretty confident it came from bats, is the answer to that question. And it mutated in the bat, and bats can live with this. They don't get sick, for instance. They can tolerate this virus. But the one that went into humans then was slightly different. And guess what changed? The spike protein is slightly different in SARS-CoV-2, and that made it very infectious for human cells. And that's why it's so troublesome, because it's so infectious to humans, because this spike, if you like, modified slightly. And now it can penetrate the lung and cause all the mischief that we know about. And that's a very important kind of narrative, I suppose. Now, if you want to know even worse, there's a worry there will be more coronaviruses. SARS was the previous one. There was one called MERS as well. They've gone into sort of China and Vietnam and Laos. They've found at least 100,000 other coronaviruses in those animals. They could jump into humans next. And there's a massive effort now to understand that to stop the next pandemic coming, because every 10 years kind of. MERS was about 10 years ago. So again, a lot of work going into bats and coronaviruses to try to understand what might happen next. And then the big question, once it was in humans then, something happened then, it jumped from the bat probably into humans. We can trace it to a seafood market in Wuhan, of course. That's when this actually began. It may have come from Laos or Vietnam originally, though, by the way. and got into the seafood market eventually, and then begins to spread. Now here's the staggering fact: a single person gets infected, and now we have 6 million people infected all over the world. I mean, it went from a single person, spread like wildfire all over the world. Every single country there's a case of COVID-19. One question is there more than one strain? And very often viruses change, they can mutate, they can become more dangerous or less dangerous. They usually become less dangerous because there's no reason for them to kill you because they want to live in your body. So they often become less virulent is the word for this. We think at the moment there's 2 main subtypes. They're called clades is the term they use for this. Some have asymptomatic features. In other words, you don't even know you have symptoms. Some become severe. And the big question is there a difference? And there's not. Both of these cause the same kind of disease. So there's no evidence as yet of this virus getting a bit milder or a bit weaker. That may happen in time. It takes a bit of time. The 1918 pandemic eventually became a bit milder, but that took a couple of years. So maybe this will happen with this virus as well. There's some hint of a less damaging strain, but still time will tell if this virus will become less dangerous. There's a risk it'll become more dangerous, of course. It seems pretty stable at the moment, to be honest. But there's 2 clades anyway that infect humans. There are tiny differences actually. If I take a sample of virus from Ireland and compare it to one in the US, there may be 1 or 2 tiny differences. But remember, there are millions of nucleotides in the RNA, and 1 difference doesn't mean anything, you know. But you can actually fingerprint them in ways, but it doesn't mean they cause a different disease, is the idea there, I guess. Now, the other key feature here then is this, and this makes this virus especially pernicious. It is the newest member of the coronavirus family that infect humans. There are 6 other members. There's SARS and MERS, and that's, you can see it on the right-hand side there. And SARS and MERS go to your lungs. They don't stay up here. They go into your lungs and they cause a very severe disease because they're in your lungs and they really drive the immune system crazy in your lungs. You get a massive inflammatory response. 35% of people with MERS died. 10% of SARS people died because it was so severe for their lungs. That's one extreme in this family of coronaviruses. The other extreme are 4 viruses. You can see them here, the blue. These cause a cold. They cause a mild disease. And in fact, 20%, as you will know, of all colds in Ireland are caused by these coronaviruses, 20%. And they've been kicking around for decades. Very mild, few sniffles, and you get over it, you know. Guess what this virus is? It's like those 2 viruses, a common cold virus, and SARS had a baby, and it's called SARS-CoV-2. This can live like the common cold in your upper airways, or it can go to your lungs, right? If it's in your upper airways, you don't even know you have it. It's a mild disease. No symptoms often, actually. But yet you can infect people. And if you're unlucky, it'll go to your lungs. And then you get severe disease, and death happens if it's in your lungs. So this is a really difficult virus, because it can spread from person to person with no symptoms. That makes it very difficult to track down. We could track down SARS and MERS because you had symptoms and they go into quarantine. This one, lots of people, maybe as many as half of the people who are infected, have no symptoms at all and are spreading it. Now, it doesn't matter if we're all like a cold. If, the common cold is pretty benign. The trouble is, some people, maybe as many as 20%, it goes into their lungs and then causes severe disease. And of those 20%, 5% are really bad disease. The current infection fatality rate, which means the number of people who die from this virus, is around 1%, which is very high for a virus, much higher than flu, say, for instance. That number moves, it's lower in some populations. Of course, the massive risk factor is age, as you know, and there's a very much higher mortality there. But in essence, the virology here, this virus can live in 2 places. If it's up here, in the airways and in the nose and so on, it's mild. If it goes to your lungs, it's severe, and that's the dangerous thing to think. And we don't really know why, by the way. That would be lots of immunologies happening to try and understand that difference. Now, of course, the main place it goes is your lungs, because they express ACE2, and ACE2 is the lock, remember, that the spike key goes into. But guess what? ACE2 is in the brain, it's in the heart, it's in the liver, it's in the intestines, it's in the kidneys, it's in your blood vessels. So this virus can go anywhere that ACE2 is and go inside those cells. And of course, what we see in patients, as you would all know as well, I imagine, is you get gastrointestinal disturbance. You get cardiac problems because now it's infecting those tissues. And most worryingly, it goes into the blood vessels, into the endothelium. And there now it wreaks havoc and causes massive coagulation. And this actually is a coagulopathy in many ways because of all these blood clots forming. People are probably dying of vascular problems. And that became clear early on. Other viruses do this. The flu can do that as well. it's especially bad with this virus, this coagulation aspect, and that's a big focus then for therapies, which I'll come back to. So, in other words, it's not just a respiratory disease. Now, not everybody gets this. I mean, some it just stays in the nose, some is in the lungs, some is in other places. But many people, we see infection of these other tissues with this virus, and then symptoms result in that infection. Now, let's look at what happens. Obviously, as I said, the good news is if 80% of people, it's mild. And of course, this depends on age. And if you're under 50, it's a very mild disease, very benign. If you're over 50 and 60, 70, 80, then it gets troublesome. So something is happening as we age. We still don't fully know what that is. It's partly your immune system is less able as you get older, like most things in your body. The immune system ages as well. The second thing we think, though, is you get a worse inflammatory response as you get older. And there's a thing called inflammaging. As you get older, there's more inflammation anyway, and that just makes everything worse. And that seems to be why older people are dying. You'll see here with the age groups, when you get to 80, there's a 10% infection fatality rate. So 10% of people over 80. Again, these are 4 separate studies here. Each dot is a different study. It's higher than some studies. So it's around about 10, 20%. Over 80 is really a problem. Under 50, very low fatality. So we know it's a disease of age, effectively. Now, the second thing is, though, and this is a very important feature of the virus, aging is a risk factor for death and for severe disease. Equally, obesity is almost as important as aging, and you can be any age. If you're obese, it's a bit like you're in your 80s. The risk of dying is much higher, and they saw this in hospitals very early on. The reason for this is, if you're obese, you're slightly inflamed anyway. Your body is a bit sort of on the cusp of inflammation because of all this tissue that's full of lipids. And that means the virus goes in and there's more inflammation and you get a double whammy. So obesity is a really important risk factor. Other risk factors are heart disease because it can affect your heart. And again, if your heart's already in trouble, you get a double whammy. High blood pressure, again, puts pressure on the whole system there. Diabetes is a risk factor because high glucose in your blood. The virus, the cells it infects, love glucose. So more glucose, more virus. So we know a lot about these extra risk factors. All of these are as important as aging. And when they talk about protecting the vulnerable and letting the young people out to run free, that's stupid because 1 in 3 people in America are in a risk factor anyway because of all these other things, you see. You can't protect 1 in 3 of the population. So it's very hard to say, let the virus run in young people and protect the vulnerable, because that's really hard to do because there's so many vulnerable people out there. That's one view anyway. Other people think we can protect the vulnerable. Many of us are not sure about that. But that gives you the overall features of the virus in terms of level of risk. Now, the other there's a number we really need. And every night in the news, you'll see the cases and the number of people in the ICU. Mercifully, that's gone down hugely. And in fact, since about May, they've noticed the death rate is going down and down and down. And the reason for this is very simple. It's because young people are getting infected and they fight it and they don't die. The second reason is they're getting better at treating them. And in hospitals now, there's various treatments I'll come back to already being used that are keeping people alive. And that's fantastic news. And this is heading in the right direction. The ultimate goal, of course, is that. Make this a non-lethal disease. Let's hope that will happen with the other things that we're all interested in. I'll come back to those in a minute. But the key number is the excess death rate, because in other words, how many extra people are dying in the world because of this virus? And that's a controversial thing. It's hard to measure. This graph, or diagram here, the purple, a very high excess death rate compared to other times, other years, say. So we know it's killing more people. This is another reason to die, basically. The big risk, of course, is if you implement lockdown measures, people die because of that. So the total excess death rate can be your policies as well as the virus. Very hard to separate those two. A lot of effort going into this, and it's still a work in progress. But the consensus is there's been an excess death rate here because of this virus. Now, of course, it could be nudging people who are vulnerable and speeding up a natural process, but still they're dying because of the COVID-19 virus. Even though they have these other things, they're still dying of it. So this is a very important number to get your head around. We will eventually have an accurate number that says this number of people died of COVID-19 and this number died because of it. And that can be because they weren't getting medical treatment, or because, they didn't get to hospital on time because they wouldn't go, or whatever it might be. In other words, they're not dying of the virus, they're dying because it happens to be in the community, I guess. So these are two very important numbers for us to understand eventually. Bottom line, though, is it is another cause of death in humans, especially in some countries. It's especially evident this excess death rate's happening. Now, that's one thing to think about. The second thing is death is one measure, of course, and you want to get that to 0. What will be very important, and the dialogue will shift to this, is a pain that lingers. This is from a science review. There is no doubt at all that a reasonable percent of people get over the virus and have long-term consequences. And these can include things like brain fog, they have confusion, concentration problems, shortness of breath, their lungs have been injured, so they can't breathe properly for months after, heart problems as well, hypertension. All of these 4 are examples of symptoms that continue once the virus has been conquered. Now, this could be, the numbers on these are still a work in progress. It can be as many as a third in some studies have these persistent symptoms. So in other words, looking at the death rate is useful and very important. Of course it is. This is equally important. You don't want to catch this virus because you may be in that category. They're called long haulers. Your life will be badly affected for months and months afterwards. And the big question is, can we treat these people and limit these lingering symptoms is the big question. And it's difficult. I mean, as you will all know, people with the flu often have long-term symptoms as well. So again, this is a feature of this virus seen in other viruses, seems especially prominent here. So again, you got to stop the person getting the virus in the first place. Because even if you rescue them and they don't die, they may have long-term symptoms, and that's got to be avoided as well, of course. Very important aspect of how we handle this disease. Now, let's begin to dig a bit deeper now into what we might do in terms of how to target it. Now, for this bit, you need to understand a bit of virology and how the virus works, because obviously what we're all trying to do, my lab included, is go after targets here to stop this virus. And as I say, you need science now to understand the virus. And here's the life cycle. There's the spike protein. It binds ACE2. You can see there ACE2. That's on the surface of the lung cell. The virus is now inside the cell. And guess what it wants to do is to make copies of itself. So the RNA comes out here, and the RNA makes lots of copies of itself and begins to make proteins and assemble a new virus. And now the new virus is released. That's the life cycle of the virus. Now, once you know that, now this was known already with SARS, and coronaviruses are similar. SARS uses ACE2 as well, for example. So we knew some of this already. This gives you targets to fire at to stop this happening, and that would be a very useful thing, as you would all appreciate. Now, the good news is this cycle happens, but the immune system is there to stop it. And the beauty of your immune system is it evolved to kill viruses. So we do get a big immune response to this virus. And this little graph here shows you this. Here's the SARS-CoV-2 RNA going down as the immune system kills the virus, and there's the antibodies going up. And remember, your immune system, they're making antibodies to target the virus. And IgM goes up, IgG. These are measured now, of course, in tests. An early question was, how long do they stay up for? And of course, they go down, and they eventually go down. That's a natural thing. Once you've cleared the virus, there's no point in your immune system pumping out antibodies. That's very inefficient. If that was true, your blood would be full of antibodies to all the infections you've ever had. So it's supposed to go away, and that was never a surprise to us immunologists. What's left behind, though, are memory B cells. The B cells make the antibodies, and there's more of them there. And then if you get reinfected, you make more antibody, and that's the basis for immunity. You know, it's also the basis for vaccination. So measuring antibodies isn't that useful, it turns out, because you might pick the wrong time, and the antibodies are gone, even though you're infected. It's too late. You can measure them as a scientific thing, you know, just to get what's called seroprevalence, but we don't see them as really important things to measure. But it's very important you get a good antibody response to this virus. And then, of course, you also get the T cells. And anybody who's done immunology, I'm going to get a bit heavier. CD8s, you remember those? Cytotoxic T cells. CD4s, various T cells come out. They are needed to kill the virally infected cell, remember, they're the CD8s. The CD4 T cells make these so-called cytokines to help B cells, and that's T helper cells, and that really helps the whole process along. Now, again, what was seen very early on was what this virus does, it kills your T cells, and the T cell count plummets during infection. And that's very clever of the virus. It doesn't want these T cells, because otherwise they'll eliminate the virus. So they go down and down and down with severity, and the viral load goes up. You see here the orangey colour, and the T cells go down. It's a pernicious aspect to this virus that it targets T cells. And then how does it do this? Well, guess what? This is evolution. Viruses are evolving all the time, and they don't want your immune system. They evolve ways to turn off immunity. And they'll turn off T cells, they'll ramp down antibodies, and they turn off what's called innate immunity. My area is innate immunity. And all these brown things here, they're in SARS. SARS makes a whole set of proteins to turn off innate immunity and stop the immune system working. SARS-CoV-2 is the same. So it's an arms race between us and the virus. Now, luckily, in 80% of people, we win. The immune system laughs at this and kills the virus. But 20% of people, it doesn't win. And it's partly because the immune system is sort of inactivated by the virus, and therefore you're not able to fight it. And that's a big area of research. Some of the susceptibility stuff could be genetic. Maybe some of your immune genes aren't working properly, and the virus wins that battle, you see. So very interesting to look at immune genes in the context of, and this is a good example of how complex the immune system is. This is an immune cell, all those little blobs or proteins in the immune system inside the cell, and lo and behold, the virus is a way to stop them. So very important part of research, I guess, to understand that. Now, with that knowledge about the viral cycle of replication, with the knowledge of the immune system, and then with the knowledge of the inflammatory process, which I'll come back to, we can now think of ways to fight the virus. Now, the vaccine is the obvious answer. The vaccine will be a safe thing, we hope. It'll bring out your immune system, you'll get the memory cells, and they will stop you getting infected. And remember, prevention is better than cure. Back to vaccines in a minute. Secondly, using antibodies themselves as drugs, these little dog-like creatures. Their ears are like an antibody molecule. Antibodies will mop up the virus and stop it, spreading. Great possible therapy there. Thirdly, of course, we've antivirals, drugs that directly kill the virus, the replication cycle. There's drugs being tested for that. And then fourthly, my area, anti-inflammatories, and they will protect your body if you're infected. Now, obviously, prevention, as I said, is better than cure. Because once you don't have the virus, because all kinds of problems. But some people will get it, and there's ways, hopefully we'll devise ways to treat you if you have the virus. And these are the 4 things I'm going to go through now gradually. This is a good depiction by the Wellcome Trust. I just cribbed this off the Wellcome. Here are the approaches again. Antivirals, there they are. Kill the virus there and stop the virus multiplying. Anti-inflammatories, protect your body, to calm the immune response. And then antibodies here, and vaccines. They'll bring out antibodies and they'll mask, see them masking the SARS-CoV-2 virus there, so that's another approach that can be used. Now, let's look a bit more in detail at the minutiae of this process. In other words, it's all very well for me to say to you, let's go after the immune system and say boost it with a vaccine, or let's develop drugs to block the inflammation. As you would appreciate, I hope, very complicated things happening here in the body. There's probably about 400 different cytokines, and we talk about a cytokine storm. There's probably 53 cell types or more in the immune system. How do you get through that forest of immunology? I mean, I've worked in immunology now for 30 years. When I began, we had a tenth the knowledge we have now. The hope is we can use that knowledge against this. And let's just start with the lungs. And lungs is the key place to get infected. You get a massive inflammatory reaction there. Macrophages are the key cell type. We work on those in my lab. Lymphocytes will cause inflammation. And there are the cytokines. They come out and they will cause the inflammatory process. So a big focus on cytokines. And this is the so-called cytokine storm. Again, I won't expect you to remember this, but these are all the cytokines. And they're coming out of immune cells, they're coming out of blood cells, they're coming out of all these different sort of tissues, are making all these cytokines. All of these go up in COVID-2. And there's great studies in the past month measuring these, which ones might be important, which ones are especially up, because they might be the ones you might try and block. So this cytokine storm is a very important feature of this. And then if we look at a bigger picture here about what to go after, as I say, it's shots on goal. Top left-hand side, there's the virus going in. Now, can you stop the virus replicating? The big hope here is remdesivir. That drug blocks the RNA polymerase in the virus and stops the virus replicating. That showed a bit of efficacy in the early trials. Remember, we never got a vaccine for AIDS. We never got a vaccine for hepatitis C. Instead, we have antivirals that kill the virus. Remdesivir is in that category. It'd be tremendous if we get an antiviral, because now you can kill the virus and give it to people, just in case the vaccine proves tricky. Remdesivir didn't really work that well. There was maybe a 30% effect, but still, it did something. And they're combining remdesivir with other things now. So that was the first little bit of fingertips on the cliff face. There's chloroquine. This is a previous talk. I won't go into that again. That was tried. Chloroquine is antiviral, and it will stop viruses replicating. Hasn't shown much in the clinic, so we've got rid of that one. I guess this is very much a moving target, of course. Here are my cytokines, various drugs to block them. With a disappointment, actually, today. Anti-IL-6. IL-6 is a very important cytokine. It goes up in COVID. There was good reason to believe. 2 massive trials, Johnson & Johnson and Regeneron. Their trials have failed. So IL-6 will not be useful, it looks like, sadly, from those trials. Anyway, and again, it's empirical. You're trying to go after something and hope for the best, almost. There are other cytokine targets being explored, so maybe other ones will work. And then finally, here I have the antibodies. Now the antibodies, a vaccine will bring them out. You can use convalescent plasma. That's from people who've got over the virus. Take some antibodies from their blood and use that. And the FDA just gave that emergency approval. Now again, we need more evidence they will work, we're not sure. On the other hand, you can make antibodies, and drug companies are very good at making antibodies. There's at least 44 now in trials. So this is using an antibody against the spike protein as a drug, and you can make them, and drug companies can make them in truckloads. Ireland, in fact, is one of the world's biggest manufacturers of antibodies for various therapies. One tiny example to give you, Lilly, that drug company. Now again, many drug companies are involved. Pfizer are doing it, GSK, they're all doing it. But Lilly have a drug against the spike protein. They're doing a prophylactic trial in nursing homes in America. In other words, if you give somebody a huge dose of the spike protein antibody, it may protect them from getting infected. And that'd be wonderful if it can protect the vulnerable. Wouldn't that be tremendous? Going back to my previous thing, if that was possible to do with an antibody, that could be very useful. That could be expensive, we don't know, but they're running a big trial to see if a prophylactic antibody will protect the vulnerable, or healthcare workers, of course, could take this as well. So it's remarkable, actually. This was always an idea with flu and other viruses. We're now seeing it happening with COVID-19, and maybe it'll get through, and you never know. And that could have use then for other diseases as well. Here's an example of the antibodies. These are all these different patients had COVID-19. They made antibodies out of their blood, and they all neutralized the virus. This is a neutralization assay. So we know many people have antibodies that can neutralize the virus. Now, of course, what you want to do is make them in bulk and give a massive dose of them. That'd be a therapeutic approach, I guess, using lots of antibodies to protect. And there's a spike protein. A lot of work on this. Which bit do you block? We now know the region that the antibody should block. It's the red part there. Get an antibody to that, and it'll stop the spike sticking in. It's fantastic biochemistry going on there, to be honest. Now, and then we think about the vaccine, of course. So antibodies are one approach. What about the vaccine? And the term herd immunity is bandied about. We've only ever seen herd immunity really with a vaccine, if the truth be told. You need a vaccine to get herd immunity safely. It doesn't happen very often with natural infections. It has happened with flu a couple of times. Remember measles? That has been kicking around for a long time. We never got rid of measles through herd immunity. We needed a vaccine. And many infectious diseases are like that. You need a vaccine to get the herd immunity to work. And this is a great diagram I just got last week, actually. It explains why. Here's the natural immune process. This is herd immunity in the topper. Let the thing run free, no immunization, no social distancing. This person gets infected. Eventually it spreads through the community, you know, and then finally lots of people die, remember, and then you will get herd immunity. But here we see the number of deaths. You can see the grey people here. So if we go for herd immunity, we will kill people for definite, and we'll kill them in large numbers with this virus. Second option is do social distancing. That will slow down the spread. Of course it will, because there's gaps between people. But again, people are going to die, smaller numbers than here. Here's the vaccine, protect, a lot less die. So the best way to stop people dying is to discover a vaccine, without doubt. And lots of other infectious diseases have shown that to be the case. Now, what's the status of the vaccine then? This is last week. There are now over 135 in development. 2 have been approved. As you may have heard, the Russians and the Chinese have already approved 2 of them without going through a phase 3. We worry about that because we need safety. Very important. 8 are in phase 3, and 2 or 3 of those are out front, and 12 and 19 phase 2 and phase 1. Now what this slide tells you is, never in the history of infectious diseases has there been such an effort with vaccines. This number of vaccines is more than were ever tried for malaria, which kills millions of people every year. So huge effort going into vaccines. Keep our fingers crossed. What's the prediction? We don't know. Making a vaccine, as I've said many times, like a horse race, you can fall at the last minute, so we still don't know. Best case scenario is March, April, May next year. There will be a vaccine that will be safe. Very important for vaccine hesitancy, of course, and you'll all be aware of that. It's got to be safe. And then secondly, you'll see a partial protection. That will do us to begin with. The effect that will have on the mood of the governments and the nations will be massive. Vaccine working in COVID-19, even if it's a partial effect. So we're keeping our fingers firmly crossed. We may get lucky. There could be a very efficacious vaccine that will really be gangbusters. We just don't know. It's a risk that we won't get one. We never got a vaccine for the common cold. Same family, right? So again, you hope for the best, I suppose, is the way to think of it. Massive effort. And it's all about adjuvants, actually, that are key immune stimulants. That's a big, big effort there. And here you see there's different strategies being used. Brand new strategies, never used before, are being tried. Because we couldn't get a vaccine for malaria. We couldn't get one for the common cold. Let's try something new. Many different technologies, DNA, RNA, proteins. You wouldn't believe the amount of science here is massive. So again, all these different approaches, one might work. And another thing to emphasize is it's very much a public-private partnership. It's not just drug companies. Governments are putting billions into vaccines. The EU is investing in it, the NIH in the US, massive support from governments and companies combined. You've never seen the like of this collaboration between the private and the public to try to get a vaccine. Really important. Now, the other thing to say is what the vaccine does is it brings out antibodies, and here's my antibodies being made. There's the spike protein, IgA, IgG there. And then you get the T cells as well, right? And they're very important. Here's my T cell types here, and here's my antibody. And that's what you need. Now, one minor little thing, which could be very important, there are people walking around with T cells to this virus already, even before the virus emerged. What does that mean? There's a hope here. Other coronaviruses, like the common cold, will bring out T cells that will cross-react with SARS-CoV-2. This is called heterologous protection. Happens in other viruses. And they're finding people now that have antibody or T cells already because they've T cells to the common cold and they now cross-react with SARS-CoV-2. That's a really wonderful thing if that's true. Because what that means is that some people have a built-up immunity already because of having colds that will protect them. So we're very interested in that discovery. More work needs to be done to confirm that in various ways. So might the common cold offer protection is a strange thing. The second thing is, if we get a vaccine against COVID-2, guess what? There'll be vaccines against the common cold next, against coronaviruses, because we've cracked it, you see. So maybe eventually there will be a vaccine for the common cold, at least the ones caused by coronaviruses. And that's kind of a hopeful aspect. And then finally, before I get to the therapies, BCG, you may have heard of this. This is a fascination now, because it turns out BCG has been known for 30 years. And that's the vaccine for TB, to put up kind of a non-specific barrier to other pathogens. There was evidence that BCG protects against flu or measles. It's causing innate immunity to come out, it's called trained immunity. And I work on this in my lab. I had a big interest in a review I just did a couple of months ago. So what BCG does here is it causes cytokines to come out. It's been shown for RSV, influenza, HSV as well, and maybe SARS-CoV-2. So it's a funny one. And now there's 7 trials running with BCG to give us kind of a bridge to a vaccine. And here's the diagram here. You might get BCG. It'll cause a bridge to protect for whatever. And then you finally get the real vaccine coming along. And BCG is safe. So again, there's a kind of a hope here that BCG will cause, if you like, a non-specific immunity against COVID-2. Very much a work in progress, but let's see what happens next with that one. Now, what's happened as well is all that's going on in the background, all this effort to make a vaccine and the BCG efforts and using antibodies, they're getting better at treating people in hospital. This death rate is going down. This is a great example. There's April and May. Look at this. And this is the overall survival rates. And you can see in every single case, there's more survival in June. See the way that's higher there, higher here? You know, maybe 15, 20% better in that age group. 70, 79, look at that. There's a 15% increased chance of survival in that age group in that very brief period. Why is that? Treatments are getting better. They're getting better at handling the patient, and physicians are fantastic. They observe, they modify the protocol. One big advance we think is dexamethasone. There it is, that you may have heard of. That was tried with severe patients. I worked on dexamethasone in the 80s. It's an anti-inflammatory drug, and it will block inflammation globally. They gave it to people on ventilators and it seemed to reduce the death rate by as much as 70% in some studies. So a global anti-inflammatory seems to be working. This has become standard of care in many treatment protocols now, and maybe one reason why there's less fatalities. They're putting less patients on ventilators as well for various reasons. But dexamethasone gives us the first of the glimmer there. And like this is some of the data. Here we see usual care. This is mortality. Here's the ones on Dex. You can see less death if you're on dexamethasone. So that's a very cheap drug. It's a great advance, we think. And there'll be loads, hopefully more examples of anti-inflammatories working in that way. Now, at this point then, you might say, look, all these approaches, vaccines, antibody therapies, anti-inflammatories like Dex, we will beat this together. And again, just to emphasize, it's the massive collaboration that's happening. Now, when you talk to your patients, and we talk to the general public, how can we give them encouragement? And there's various ways, and this is a little bit that's a fascination. What's staggering is, if you forget all the science for a minute, and now what has science brought to this? Diagnosis, we can now tell who's infected from doing PCR on the sample. That's about the size of it at the moment, terrifyingly. Our response has been no different to 1918, before viruses were even discovered. Look at this slide here. This is the advice in the 1918 pandemic. Wear a mask. Look at that. You know, wash your hands. It's the same thing. You see this? I like this one. Do not disregard specialists just because you do not understand, because we get that the whole time. And it's amazing, that list of what we do here is the same as we're doing now, you know. So let's hope all this science actually makes a difference. We've discovered viruses since 1918. We've discovered a lot about the immune system. We're using that knowledge now as better ways to treat this virus. Now, of course, you'll know all the risks. I needn't tell you, there's a great This is the Texas Medical Association. These are degrees of risk, and people are asking what's risky, what isn't. All the government guidelines are based on risk. Guess what the highest risk is? Pubs, as you know, and crowded places are in red here, and you can go through this, all these different risk levels all the way down. Being outdoors is a big de-risker. You'll all know this in spades, I imagine. This is a good paper that came out. Different indoor settings. Risk of catching the virus. Here's an indoor gathering, poorly ventilated, nobody wearing masks, big increase in spread in that environment, right? On the other hand, if you have a bus ride here, look at this, and it's well ventilated, we're all wearing masks, almost no risk of infection. So we know an awful lot now about where this virus spreads. Crowds is the obvious thing, you know, and badly ventilated spaces, close contact between people, these are all obvious, and all the public health messages are about that. And what that means, it's spread indoors. You know, make the indoors the outdoors. This is the public information thing I quite like. Wear your mask. The evidence for that's compelling now. It's not perfect. There was no clinical trial with masks. But if you're sensible, you look at the evidence there is there and go, wear masks for definite. And look at this, you know, interactions with outsiders should be limited. There's a hairdresser. Just make sure you don't have too much close contact. And of course, we began pressing from, there's my lab, all wearing masks. We were doing this back in March because I began to, now mind you, I changed my mind. Back in March, and back in February actually, I said, look, the guidelines were wear a mask if you have symptoms, if you're coughing. That changed when we realised you can spread this just by speaking. So that wear a mask, because you could. And then secondly, asymptomatic spread. That made it sensible. Like people who don't wear masks, do they still cough into their elbow? I wonder why they're doing that. You know, same reason, wear a mask. And then lots of science supported this, that masks were very useful. I like this one here. Look, what if I told you I could give you something that would greatly prevent COVID-19? Is it a vaccine? No, it's a mask. You know, the effect of the mask is great on preventing. How about the other measures, of course? Here's a good diagram. This person isn't wearing one, these are. You see, if they both wear them, almost no spread between the people. So you protect the other person, as you know, by wearing a mask. Here's some of the science. Look at this. This is someone wearing a mask and measuring all the droplets. Look at this. No mask here. Lots of stuff comes out. Now, that is just sneezing. This is speaking. Look at this. These droplets are coming out just by speaking. Put on a mask, no droplets. It's obvious that you're going to stop the spread by wearing a mask. And lots of science like that backs up this notion. Now, the other big public information thing is avoid the 3 C's. Japanese did this, you know, closed spaces, crowded places, close contact. Avoid those 3. It's obvious, you all know this. Keep ramming that message home. There's even this from the WHO. Clean your hands, cough and sneeze into your elbow, avoid touching your eyes, avoid crowds, 1 metre, 2 metres, of course. Keep wiping down surfaces and then isolate yourself if you don't feel well. You know, that's one poster that would typify that in many ways. And this is another good one, like about schools reopening. To reopen schools, you got to get the community spread down. Here is reopen a school, you know, if it's uncontrolled epidemic, control the epidemic, open schools. If it's uncontrolled, open schools anyway, kids get infected, close schools again. So it's obvious to get the numbers down. And you can just follow these measures and that will make sure that the schools will open safely. Our big fear is the winter, of course, because we all go back indoors. And then we've got to watch these next few months. We're going to come into a difficult winter. There's no doubt schools will close occasionally and kids will be in and out. That's the reality of how contagious this is. And then you'll be worried about flu and the coincidence of flu with COVID-19. Now, the good news there is, in Australia, these are different years and different rates of flu, right? This year, it's flat. No flu, hardly, in Australia, because these measures that we've just gone over there stop the spread of flu as well. We might get lucky. Maybe there'll be less flu this winter. If a bad flu outbreak coincides with COVID-19, that will break the health service in this country. So we've got to be very mindful of the winter coming is the key thing to say there. Now, finally, a bit of my own work. That bit I just gave you is about the public information, but which you must keep ramming down people's throats. My own work, I'll give you one little example. My lab now is working on COVID-19. We have 5 projects running at the moment. I've applied what I know about inflammation and I've worked on cytokines for 30 years, macrophages to COVID-19. And there's one specific thing, we're in this realm here. This is the world of cytokines, you may remember from the earlier slide. We're working on a molecule of itaconate. I want to give you that very briefly. We've got great hope that this might work. There it is. That's what itaconate looks like. And I've got 5 projects now working on this molecule. Now, why do we work on this? We discovered this molecule in 2018, or we published on it. It was 2016 it began. 3 labs at the same time find this molecule. It's made naturally in your body. It comes off Krebs cycle. That will terrify any people who remember their years doing biochemistry. So Krebs cycle comes off Krebs. Guess what? It's a potent natural anti-inflammatory metabolite. We showed it could protect against sepsis. Now, sepsis is a bit like COVID too. This is caused by bacteria. but mice will die with a septic model. Give them itaconate, they live for longer. See that? So it's anti-inflammatory. It's stopping. Now the features of sepsis are similar in COVID too. And then a paper came out about a year ago on Zika virus. And this lab in America contacted me to collaborate because we discovered itaconate's properties. And they tried itaconate and Zika. And look at this. Here are mice dying of Zika. Give them itaconate and they live. So it's antiviral. It can stop Zika killing you as well. That paper, nice diagram. There's itaconate sprayed on Zika. Now imagine that that's COVID-19 now. And guess what? We've tested that now. And I'll go to this next slide here. Here's our latest data on this. Now we're collaborating with labs in Holland and Belgium. We work on SARS-CoV-2, they're SARS labs. I met them in January actually at a conference before the whole thing took off, and we began to collaborate. And here's a model where you infect lung cells with SARS-CoV-2. We sent them our drug, itaconate, and they tested it for us. And look at this, 20% of the cells are dead. See that there? In response to SARS-CoV-2. We gave those cells our drug, and look at this, the dose response, they all live. You get to this dose, no cells are dying. So we're protecting lung cells, real human lung cells, from being killed by this virus. And we think it's stopping the virus, actually. It's stopping it dividing in various ways. And it's also having sort of protective effects on the cells. There's our first hint that this could be used to treat it. And then I nearly fell off my seat. This paper came out about a month ago now. Everything's coming out so fast. This paper in Cell Metabolism, they measured metabolites in patients' blood with COVID-19. They just took blood from patients, measured all the metabolites, very complicated. Look what they found. COVID-19, interestingly, itaconic acid, our drug. Remember, it's a natural drug. A macrophage-specific metabolite derived from cysticonatate was progressively reduced with COVID-19 severity. That got my attention. It goes down and the disease gets severe. If we give it back to patients, we might protect them. And that, in the middle now, testing to see if we can replace something that's gone and suppress the virus and suppress inflammation and severity in those people. That's our great hope. And there's our first bit of data to support it. We've got the data. Every day we're getting new bits of data. It's extremely exciting. So let me finish now on a couple of things. Big journey we've been on, I know. I've given you lots of science there. The hope for treatments and all the rest of it. And remember, the public information for the public about avoid the 3 C's and the masks and all that stuff is still very important. Here's a fantastic epidemiologist. He's in the University of Edinburgh. I'm a big fan. Devi Sridhar, follow her on Twitter because she's brilliant. Everybody should be on Twitter, but not for the haters. Just follow people like me and Devi. You'll be all right then. So Devi says this. Look, there are few short-term options. One, let the virus go and thousands die. Millions die in America. Lockdown, release cycles will destroy the economy and society. That's hopeless as well. She wants aggressive test, trace, isolate and support with physical distancing. That's the only way out of this in many ways without these other things. Test, 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 trace, isolate. We need saliva tests. They're coming up next. There's a massive effort about different tests, for instance. So this is the way forward, at least one view from Debbie. The others are just unacceptable. And many of us agree with this, and it's a very important point to bring home. And so we might now think about the future, possible scenarios, and this is my the crystal ball as a scientist. You've got to be careful because they'll come back to haunt you. This is my view, and many of us, not just me. First of all, there may be some immunity will build up in the population. That'll be great, even a bit of immunity. In the young people, if they become immune, the more people who become immune, the better. And there is evidence now that you can get reinfected, but it won't be as severe, or you might have no symptoms at all. There's the first hint now that immunity might happen anyway, and that's a fantastic. It mightn't last for long, it might last for a year, but still, if there's a bit of immunity building up, that's great. Now, the vaccine, its job is to do that. It's to build up immunity. That will help tremendously, even if it's partially effective. My prediction is there might be a partial effective. That'll help because we'll see more immunity in the population. Therapies in hospitals will continue to improve. Great hope there. And antibodies in particular. I'm very hopeful here because these antibodies are in development. They're safe. They will kill the virus or protect. And I bet that'll be the big advance that'll happen in the next 3 months or so, and because these trials are running. And then prophylactic. Give these things before you're at risk of infection. Nursing homes or healthcare workers, of course, are uppermost in our minds. The vulnerable have a prophylactic approach. Could be antibodies, could be antiviral. And now the fear begins to dissipate. If any of these work, we're in a better place. The fear begins to go away. I don't know which one's going to get there first. I'm predicting the antibody approach maybe first, but let's just keep our fingers crossed. This frenzy of activity is incredible. If it doesn't work, science will have failed. And I don't believe that science ever fails. So I'm optimistic that some of these will actually work in the long run. And again, the final message is we'll do it together. All of us, GPs, scientists, the general public, we've all got to row in behind. All this aggro we see is a waste of time. let's all beat this together. Everybody can help. You're following all the measures, all the science, all the research. Keep going, and we're going to get there and we'll beat it. Thank you very much.
Thank you, Luke. That was a very informative chat. Having had COVID arrive to my practice, which is in Glasnevin from day one, been party to a lot of things happening and experiences, and there's every week throws up new experiences. But one topic which is something that comes up among medics regularly is the danger of viral load to medical practitioners, nursing practitioners, anybody working in the clinical setting. Can you just give us a few words on that and your thoughts on that, please?
I can, yeah, but this is actually the number one variable in many ways, and it's obvious, of course. The higher the viral load in someone who's infected, the greater chance of spread, and of course, if the person who's being infected, the bigger the load that goes into them, the worse the disease is going to be, and this has been known for a long time with other infections, obviously. So it actually is all about we call it dose as well. The dose of the virus is determining in many ways. It's obvious high dose is bad, low dose isn't too bad, and of course, if your immune system is pretty active, and that means you're pretty healthy, if a lower dose shouldn't be that troublesome, because your immune system can work quite effectively and eliminate it. So it really is all about the dose of virus coming in. That's why healthcare workers, of course, are on the front line, because they're getting exposed to the risk of high doses is obviously, very, very prominent in a healthcare setting. So it's a really important thing to think about.
And is there a cumulative factor to that, Luke?
It's very difficult to pin it down in some ways. I mean, years ago, people were measuring this with other viruses. And different times of the day, the dose can change. In other words, it's a battle with your immune system the whole time. And maybe just dumb luck, for 12-hour period or whatever, there's a very high dose in the airways. The virus has been shedding a lot. And then the person coughs or shouts or whatever it is, then it comes out. So it's quite hard to pin down, really. And then the second thing that's a bit tricky is it doesn't necessarily correlate the symptoms. You think if someone's infected, when they get a big pulse of virus, they should have more symptoms, and that may not be the case. So it's a strange one to try to pin down really kind of with real accuracy.
Okay. Another question that's coming in here from GPs is, recently it was on the CDC website about these supposedly secondary infections, people who are getting the difficulty getting the COVID for the second time, be it seroconversion or whatever. But also what is written up on the CD website is the fact that people who've been infected, when they've tested it, yes, they've said a small number of people seem to be getting a second infection and it's seroconvert or mutated. But equally what they're finding is people who were infected were continuing to extrude the virus for many weeks or months onwards. Can you just comment on that?
Yeah, that's a work in progress, right? I mean, there will be it's like most human traits to be a normal distribution, and most people after 2 weeks say it's gone effectively and they shouldn't be infectious beyond that. But there will be a range, and there'll be some people way beyond the 2 weeks may well still be infectious. Trying to kind of get more data on that and try and pin it down. So you're going to see variation, and all we can do is the average response. It's very rare to see someone 3 months out still being infectious, if you know what I mean. There may be tiny numbers like that, but it is very much a work in progress.
Okay. And this is going to be the last question which is coming in. GPs are managing things in a variety of ways, but one thing that's coming up is we're asking patients to wear masks, and some of them are turning up with visors, which most GPs, if not all GPs, are unhappy with. And certainly also in my own practice, I've had a number of people working in the public sector, working in buses, working in various form of transport, be it train or whatever, and they're meeting people trying to get on their transport, and they could be bus conductors or drivers, and basically they're nervous to be allowing people getting on these form of transport with just a visor, but equally they don't want to confront these people because the response can be quite aggressive at times. Can you just give us your views on the benefits of a mask versus a visor, and what are your thoughts?
Yeah. Sure. Yeah, again, the science there wasn't much science on visors in truth, and that makes it challenging to come to a definitive answer. But lately, it's bad news, really. Visors aren't that good. And in fact, if anybody wants to dare follow me on Twitter, not that I'm recommending Twitter, but I've just posted a video of an experiment where they compare a visor to a surgical mask. And it's very complicated. It's based on liquid nitrogen. It's a good way to measure aerosols, basically. And the visor stuff gets out the bottom. Now, you can use common sense here, of course. We all know this. If you're wearing a visor, stuff will get out of the visor. If you're wearing a cotton mask, and remember, cotton masks are fine, that's much better at stopping aerosols coming out. And again, the science now to back that up. So the CDC have changed their kind of guidelines, partly based on this science and partly based on common sense. Now, a visor is better than nothing, remember, so there's degrees of it. You know, no mask is no good, obviously. A visor will help a bit, and then the cotton mask is really good, you know. So there's a gradation here. But I would be strongly recommending people wear cotton masks instead of visors, because they give that extra bit of protection.
Okay. Thank you very much, Luke. I'm going to end it on that question. I'm going to go back to thanking Menarini for arranging this. I think it's been informative. I think it's been dealing with the gremlins has been good fun, I can tell you. But I'd like to thank our three speakers, Stephen Lane. I'd like to thank Ivan Cassidy and Luke O'Neill. And basically for myself, Ray Wally, on behalf of Menarini and GP Masterclass, thank you very much. Cheers.